2, 1. Please start. We are live.
Okay.
Good
Hello,
evening.
good evening, everyone. It is a great pleasure to welcome you all for this very exciting scientific webinar, Breast Cancer Update. Now, it's a great pleasure to invite Dr. Gaurang sir, a DM hematologist, co-founder of Oncowin Cancer Center, Ahmedabad. It's over to you, sir.
Thank you for the kind words. Good evening and warm welcome to everyone. So we have 2 days of breast cancer update. Yesterday we discussed some molecular and genetic aspect of the breast cancer with a new update in HR positive breast cancer, and there was a panel discussion regarding HR positive HER2 negative metastatic breast cancer. And now today we will be discussing regarding a main topic, very aggressive cancer that include HER2 positive and triple negative breast cancer. We know that approximately 20% cases of our approximately 20% of cases are HER2 positive breast cancer, and 10 to 15% cases are triple negative breast cancer. And we have in our panel discussion, there are 3 panel discussers in today's webinar, and there are 4 lectures. So without wasting much time, I will invite our first speaker, Dr. Rahul Kulkarni. He is a consultant medical oncologist and is attached with Sahyadri Hospital, and he has his own clinic, that is Oncowin Clinic at Pune. And he will be speaking regarding 2 abstracts. First abstract is Destiny Breast 2, that comprises the TDM TDXD in HER2 positive MBC that is previously treated with the TDM, and second is Destiny Breast 3 data, and this TDXD head-to-head comparison with TDM1 in previously treated HER2 positive MBC. So over to you, Dr. Rahul.
Thank you, Gaurang sir. And first of all, at the outset, I would like to thank the organizers, Dr. Hitesh and Dr. Gaurang sir, and also for giving me this opportunity and sharing the trial data. So let me share the screen. I hope my screen is visible.
Yes, sir, it's visible. Can you please make it full screen?
Yes. Okay, is the slide visible now?
Yes, sir.
Okay, so as already discussed by Dr. Gaurang sir, the topic given to me for next 15 minutes is about 2 abstract data regarding HER2 positive breast cancers. The first one is the Destiny Breast 02 trial, which evaluated trastuzumab deruxtecan in HER2 positive MBC patients who were previously treated with TDM1. And the second one is Destiny Breast 03 trial, which evaluated trastuzumab deruxtecan head-to-head versus TDM1 in patients who were previously treated with HER2 positive MBC. Both these abstracts were presented in SABCS 2022. So just a quick introduction, we all know that though a lot of progress has been made regarding treatment with HER2 positive MBC patients, but still there is an unmet need. Initially, trastuzumab, pertuzumab and taxane was established as a first-line standard of care in patients with MBC based on the Cleopatra trial. Then came the TDM1, which was evaluated based on the Emilia trial, but whatever said and done, even in the second or later lines of treatment, the median PFS which was achieved was around somewhere between 6 to 9 months. So that was the unmet need, that patients beyond second or third line, there was a scarcity of the drugs which were available. And that's where came the TDXD, that is trastuzumab deruxtecan, and it showed a robust activity even in patients who were previously heavily pretreated, that is more than 3 lines of treatment. And that was evaluated in the phase 2 Destiny Breast 01 trial, and that show a robust PFS of around 19.4 months. And that led to the regulatory approval globally. And given this data, TDXD was then evaluated in a head-to-head trial to compare versus TDM1. So just to set the context, TDXD or trastuzumab deruxtecan is an antibody drug conjugate which is composed of 3 components. It's a humanized anti-HER2 IgG1 monoclonal antibody with the same amino acid sequence as trastuzumab, but it is covalently linked to a topoisomerase 1 inhibitor payload. It's an exatecan derivative, and it is linked via a tetrapeptide-based cleavable linker. So there are 7 important points. First is the payload, that is a topoisomerase 1 inhibitor. The potency of this payload is high. The drug-to-antibody ratio is also high, and the payload has a short systemic half-life. The payload also has a stable linker, which is tumor selective, and it also leads to bystander anti-tumor effect. So these are the important distinguishing points between TDM1 and TDXD. First and foremost is the mechanism of action of the payload. It's a topoisomerase 1 inhibitor with TDXD versus antimicrotubule inhibitor. And even the antibody drug to antibody ratio is higher in TDXD, and the linker is tumor selective. So this is just to set the context. And with this context, now let us move to the main two trials. The first trial, as we have already discussed, is the Destiny Breast 02 trial. It evaluated trastuzumab deruxtecan in HER2 positive MBC patients after use of trastuzumab emtansine. So it was a multi-center open-label randomized phase 3 trial, which included patients with HER2 positive metastatic MBC patients which had progressed on prior trastuzumab or trastuzumab emtansine. These were stratified to receive either trastuzumab deruxtecan in a dose of 5.4 milligram per kilogram every 3 weekly versus treatment of physician choice, which included either LabCap or Tras plus capecitabine. The primary endpoint was PFS. The key secondary endpoint was overall survival, and the other secondary endpoints were response rates, duration of response, PFS, and safety analysis. So these are the baseline characteristics. As we can see that the baseline characteristics were fairly well matched in both the subgroups in respects to the HER2 status, hormone receptor status, performance status, or even the baseline brain metastasis. Point to note that the patients with baseline brain metastasis were also included. And these are about the previous therapy details. You can see that most of the patients were heavily pretreated. The median number of prior lines of systemic therapy was 2 in both the subgroups, and almost 99 to 100% of the patients already had received trastuzumab or TDM1. Even 78% of the patients had received pertuzumab prior to enrollment of this trial. So even in these kind of previously heavily treated patients, when the PFS and OS data had come, we can see that the PFS achieved with trastuzumab deruxtecan was 17.8 months versus 6.9 months, almost a 10.9 months improvement in the PFS with TDXD. Also, the median overall survival was 39.2 months with TDXD versus 26.5 months with the treatment of physician choice. So almost 12.7 months improvement in the overall survival. Both these survivals, the improvement was statistically very, very significant. So that is a very important outcome to note. And also another point is that around 70% of these patients with physician's choice treatment later, they were able to receive the new anti-cancer treatment. And 25% of the patients also received TDXD in a post-trial setting. Another important point is that, though it is not mentioned in this table, PFS, which was seen or which was evaluated in all the subgroups, it was also seen that patients with the baseline brain metastasis also did significantly well. So PFS in these patients with brain mets was around 14 months with TDXD versus only 6 months. So very, very important. We know that these patients are very bad prognostic, but even with these patients, the median PFS is more than a year. Another important secondary efficacy endpoints include the response rates. It was to the tune of around 70% with TDXD versus 30% with physician's choice treatment. Again, the chances of complete response was around 14% with TDXD. So it was really very, very encouraging results. Rest all other evaluable efficacy endpoints were also significantly better with TDXD. Regarding the important point which comes is the safety. We all know that there is a different safety profile for toxicity profile for patients who are treated with antibody drug conjugates. But even after that, we can see that the patients or chances of getting more than or equal to grade 3 side effects was almost similar in both the arms. But there was a slight increase in the chances of drug discontinuation with TDXD. We'll come to know why it was happening. But if you see the other point, the chances of dose reductions were slightly lower in TDXD. Now, the most important cause of drug discontinuation with trastuzumab deruxtecan was the interstitial lung disease or the pneumonitis, which was seen in around 6 to 10% of the patients. That was the reason why most of the patients or 10% of the patients had drug discontinuation. The other arm had palmoplantar erythrodysesthesia, mainly because of the capecitabine or lapatinib. Apart from that, we know that around all other side effects which we commonly see include the hematological side effects were more common with TDXD. Apart from that, nausea, vomiting, alopecia, constipation, these are the common side effects which are generally observed. But whatever said and done, almost median treatment duration with TDXD was around 11.3 months. So even after these side effects, many of the patients, they could take treatment for almost a year. And again, the main adverse events, which are of special concern are mainly interstitial pneumonitis and the LV dysfunction. And we can see here that though around 10% of the patients had interstitial pneumonitis, but the chances of getting it in a grade 4 or 5 are almost negligible. That is only 0.5% had this problem. So we can manage it if we can diagnose and treat it properly. And a median time to develop this ILD is around 9 days. That is around 6 to 7 months is the time where this side effect can be seen generally. The other side effect is the LV dysfunction. We all know that anti-HER2 agents are prone to cause LV dysfunction, and it is also seen in around 4.5% of the patients with TDXD. But again, patients getting more than or equal to grade 3 LV dysfunction was only 0.5%. So again, very manageable. So to summarize, this trial showed that TDXD significantly improved the PFS and OS compared to treatment of physician choice, and it statistically significantly reduced the risk of progression or death. The PFS was significantly improved, the OS was significantly improved, and no new safety signals were observed. Coming to the next trial, Destiny Breast 03 trial. This evaluated trastuzumab deruxtecan versus TDM1 upfront in the previously treated HER2 positive MBC. This was again a randomized multicenter open-label phase 3 study. It included patients with unresectable or metastatic HER2 positive breast cancers who had prior trastuzumab and taxane in the metastatic setting, or either in the adjuvant setting who had an early recurrence of less than 6 months. These patients were stratified to receive either trastuzumab deruxtecan or TDM1 in a every 3-weekly schedule. The primary endpoint was PFS. The key secondary endpoint was overall survival, and the other secondary endpoints were overall response rates and the duration of response and the safety signals. Again, the baseline characteristics were well matched in both the subgroups. The median prior lines of therapy in both the subgroups was 2. And you can see here the curves are widely separating. So we can see the difference in the PFS. This is the updated PFS, and we can see that the median PFS was 28.8 months with TDXD versus only 6.8 months with TDM1. So almost 22 months improvement in the PFS, which is excellent as compared to the TDM1. And the hazard ratio was 0.33 with a p-value of less than 0.001. So it was excellent outcome, which was astonishing. And again, in respect of overall survival, this is the updated OS analysis. We can see that the curves are again separating, though the median OS has not yet reached in both the arms. But yes, definitely the p-value is significant, and it has been shown that the overall survival is better in TDXD as compared to TDM1, and it is shown that this improvement is better across all the subgroups, irrespective of the hormone status, irrespective of prior pertuzumab use, or irrespective of even brain mets, as also the number of lines received. So you can see the forest plot where you can see TDXD is far way better as compared to TDM1. Again, the waterfall plot also shows the same, that the response rates are much better with TDXD as compared to TDM1. The overall response rate was 78.5% with TDXD compared to 35%. It is almost double. And even the chances of complete response was 21% versus 10%, almost double. So again, all the other responses were much better with TDXD as compared to TDM1. The side effect profile, again, they are slightly different. TDM1 more common to cause thrombocytopenia. TDXD, as we have already seen, more chances of interstitial pneumonitis, around 10%. But if we see the rates of drug-related more than grade 3 adverse events, it was almost the same in both the arms. So I think that should not be a cause of worry or a factor to consider between these two agents. And again, other side effect profiles were almost similar in tune of whatever is the known adverse effect profile for these drugs. So again, to summarize lastly, based on the Destiny Breast 03 trial, TDXD has shown significant improvement in the PFS and OS, with 36% reduction in the risk of death compared to TDM1 in patients who were previously treated with HER2 positive MBC. And this OS benefit was consistent across all the subgroups. So based on these data, even ESMO and NCCN guidelines have now preferred TDXD as the first category drug of choice in the second line patients who were progressed on anti-HER2 agents. Thank you.
Thank you, Rahul, for excellent talk. So I share my few thoughts. See, TDXD has a robust data right now, and it has shown in various Destiny Breast trial regarding the PFS and OS advantage. And I am sure that in future it will be coming up as a adjuvant as well as neo adjuvant in the future. But my concern is that that ILD. So in various trial, it has shown that the ILD component is ranging between 8 to 15%, and directly related to the case fatality rate. So what is your take on, and what is your apprehension?
So definitely, sir, the apprehension point is there. But if you see the data, as I already mentioned, that the chances of getting a grade 4 and 5 or fatal interstitial pneumonitis was only to the tune of 0.5%. So maybe as we evolve, or maybe as we use the drug more commonly, we will be able to manage or identify the early signs of this ILD, and maybe we can prevent the fatal events. Obviously, we cannot avoid the chances of ILD if the patient has to get it. But obviously, if we want to achieve this long PFS and OS, I think these kind of side effects we will be learning to manage this. That is what I feel.
Okay, fair enough. So after Lucy talk of Dr. Rahul, so we'll move to the dual anti-HER2 agent. And my next speaker is Dr. Hitesh Khatwani. He's my colleague and co-founder of Oncowin Cancer Center. And this session is sponsored by Roche. And he will be talking about optimizing therapy in HER2 positive breast cancer with trastuzumab plus pertuzumab combination. So over to you, Dr. Hitesh.
Thank you, Gaurang Bhai, for the kind introduction. Try to share my slides. My screen visible?
Yes,
Yes.
sir.
Yes,
It's
yes, yes.
visible.
Okay. Good evening, everyone. So I'm going to talk about optimizing therapy in HER2 positive breast cancer patients with trastuzumab and pertuzumab combination. We all know that pertuzumab plus trastuzumab combination has transformed the landscape treatment and the standard of care for most of the patients with HER2 positive breast cancer. If we talk about neoadjuvant setting, we have Neosphere and Trifina trials, which showed that dual HER2 blockade with chemotherapy significantly improved PET-CR in the range of 15 to 20% more than single HER2 blockade. In adjuvant setting, we have strong data from Affinity that in patients with high risk node positive early breast cancer, dual HER2 blockade with chemotherapy decreased risk of recurrence or death by 28% as compared to single HER2 blockade with chemo. In metastatic first-line breast cancer, we have Cleopatra trial, which significantly showed that pertuzumab-trastuzumab combination with chemotherapy had significantly improved median OS by around 17 months as compared to trastuzumab with chemotherapy and placebo arm. So, pertuzumab plus trastuzumab plus chemotherapy is approved and recognized by all the international guidelines and the standard of care for most of the HER2 positive breast cancer patients. This is an age-old slide which shows the pro forma of management of most of our HER2 positive early breast cancer patients. And we know that for patients with T2 or more advanced disease or node positive disease, dual HER2 blockade with chemotherapy for 4 to 6 cycles in neoadjuvant setting followed by surgery, and depending upon pathological CR, if patient is having PET-CR, then to complete pertuzumab plus trastuzumab based regimen for total 1 year versus TDM1 for 14 cycles in patients having resident invasive disease is standard of care. While for patients with clinically T1 and 0 disease, afferent surgery standard of care, and adjuvant HER2 based therapy depending upon pathological staging would determine the further course of action. So while our routine practice, since many years we have been using IV infusion of pertuzumab and trastuzumab in our few patients, but the problem with IV infusion of pertuzumab and trastuzumab is that usually we have to infuse both the drugs in sequentially, and we have to have some observation period after infusion, which creates some congestion at clinics and hospitals. Again, there is a challenge of improving resource utilization from point of view of hospital as well as from hospital staff's point of view. There is again concern of venous access in many of our patients, and we also need to have a port or PICC line access for most of our patients while we use IVPH. So to overcome this, Roche has come with a novel concept, that is PHESGO, which is first combination in oncology to combine two meds, pertuzumab and trastuzumab in one vial for subcutaneous injection. So basically, Phesgo contains same antibodies which are approved, IV pertuzumab and trastuzumab, but it by a different route of administration, that is subcutaneous administration. And in this formulation, we have recombinant human hyaluronidase, which allows to administer this drug in large volume subcutaneous. So Phesgo is ready to use fixed dose combination administered by subcu injection in thigh approximately over 5 to 8 minutes. If we talk about addition of human hyaluronidase, this addition of human hyaluronidase on the subcutaneous site allows us to inject large volume of fluids, because if we don't add human hyaluronidase, then in subcutaneous layer we have hyaluronin fibers and collagen fibers, which limits injection amount to less than 1 ml. But when we add human hyaluronidase to Phesgo, it basically degrades the hyaluronin on a temporary basis without any structural changes in molecular structure. So we can infuse a large amount of fluid, say 10 to 15 ml, and within 1 to 2 days, there is rapid clearance of this hyaluronidase and normal structure of skin is established. So adding this human hyaluronidase allows injecting large volumes of injection of Phesgo, that is around 10 to 15 ml. So we can see this in slide that if we don't use human hyaluronidase, then after infusion of 10 ml of fluid, there can be local swelling. But when we use hyaluronidase, the swelling does not happen. But whenever we change the formulation, change the route of administration of drug, and we combine 2 drugs in one formulation, then we need to have pharmacokinetics data, efficacy data, as well as safety data. So the Phesgo clinical development program, we had phase 1B data, where dose confirmation of pertuzumab with Phesgo was done, according to which Phesgo recommended dose is 1200 mg of pertuzumab in loading dose, followed by 600 mg of pertuzumab in maintenance dose, while dose of trastuzumab is 600 mg throughout. For pharmacokinetics, efficacy and safety and preference, we have Federica and Francesca trial ongoing. However, primary analysis of these trials have already been published in SABCS 2019 and ESMO 2020 respectively. The next few slides will be having overview of these trials. B030185 was a phase B trial of fixing dose of pertuzumab for Phesgo, and in this we had 8 cohorts. We won't go into the details of this, but we had 2 groups. Part 1 included healthy male volunteers and part 2 included patients with EBC, and this trial helped us to select the loading dose of 1200 mg of pertuzumab and maintenance dose of 600 mg of subcu pertuzumab to be used in Phesgo. Basically, PK data in healthy male volunteers and in early breast cancer patients predicted that these doses will result in equivalent pertuzumab serum exposure to what we get in Perjeta IV 840 mg in loading dose, followed by 420 mg in maintenance dose. And dose finding process of this trial used same method that was used for trastuzumab subcu doses. So PK and safety results of this study supported further development of Phesgo. Based on this, phase 3 Federica trial was conducted. It was a non-inferiority study assessing PK efficacy and safety of pH fixed dose combination subcu, that is Phesgo, versus pH IV. This was a phase 3 trial where patients with stage 2 and stage 3 HER2 positive breast cancer were randomized in 1:1 fashion to 4 cycles of anthracycline based regimen, followed by standard of care at that point of time, that is Taxane 4 cycles, followed by combined with pH IV for 4 cycles. Basically 12 weeks of Taxane plus 4 cycles of pH IV versus pH fixed dose combination subcu for 12 weeks in neoadjuvant setting. And after surgery, patients continued with the same combination of pertuzumab and trastuzumab, either in IV sequentially or in subcu setting, for completing 1 year of combination. primary endpoint was non-inferiority of cycle 7, that is pre-dose cycle 8 pertuzumab serum C-trough. Secondary endpoint was non-inferiority of trastuzumab serum C-trough pre-dose 8 cycle, pathological CR, safety and survival data. If we talk about the primary endpoint, that is pertuzumab serum C-trough, we can see that with Phesgo, the pertuzumab C-trough was 88.7 microgram per ml as compared to 72.4 microgram per ml of IV pertuzumab plus trastuzumab arm. And is secondary endpoint, that is trastuzumab serum C-trough, which was 57.5 microgram per ml in Phesgo arm as compared to IV PH arm, which was 43.2 microgram per ml. So the lower limit of 90% for E serum trough and H serum trough exceeded the non-inferiority margin of 0.8. That is primary endpoint as well as secondary endpoint of pertuzumab and trastuzumab C-trough was matched. Talk about other secondary endpoints. Pathological CR was similar in intent to treat population, that is 59.7% in Phesgo arm as compared to 59.5% in IV arm. And if we see PET-CR by body mass index, it was no different in two arms except from some patients in underweight category. If we talk about the safety profile of Phesgo was comparable with IV pertuzumab and trastuzumab formulation. We can see that grade 3 adverse events were comparable. Serious AEs and death were also comparable in both arms. In fact, discontinuation rate was slightly lower in Phesgo arm. We talk about other adverse events. Again, they were well matched in both the arms. There was no significant difference in adverse events in Phesgo arm versus IV pertuzumab plus trastuzumab arm. Again, if we talk about incidence of AEs of interest, that is diarrhea, neutropenia, cardiac dysfunction, or anaphylaxis reaction, these were similar in both the arms. There was no meaningful difference in cardiac safety between two treatment arms. You can say that Phesgo showed non-inferior PK versus pertuzumab plus trastuzumab IV with comparable efficacy and safety from this study. Talking about patient preference of Phesgo versus IV pertuzumab plus trastuzumab. It was a Francesca phase 2 study which assessed patient preference for Phesgo versus IV pertuzumab plus trastuzumab. In these patients with HER2 positive EBC who have completed neoadjuvant PH plus chemo and surgery were randomized in 1:1 ratio in adjuvant setting. It included of two arms, that is crossover period, when patients in first arm received IV PH for 3 cycles, followed by crossover to subcu Phesgo for 3 cycles. In other arm, patients received subcu Phesgo for 3 cycles, followed by IV PH for 3 cycles. And after crossover period, patients were referred to treatment continuation period, where patient chose between subcu arm versus IV arm according to patient's preference to complete total 18 cycles of trastuzumab plus pertuzumab combination. Primary objective was patient preference for Phesgo versus IV. Key secondary endpoints were patient satisfaction, patient's choice of formulation, health-related quality of life, healthcare physician perception, as well as safety and tolerability, including switch data, whether we switch from subcu to IV or vice versa. So coming to the most important parameter, 85% of the patients preferred subcu Phesgo as compared to 14 to 15% of the patients who preferred IV pertuzumab plus trastuzumab. The main reasons for subcu preference was less time in clinic and more comfort during administration. And more patients were very satisfied with Phesgo, that is 88% as compared to IV pertuzumab plus trastuzumab combination. Because this treatment had no impact on patient and healthcare physician speaking time. In fact, most patients had enough time to talk with their healthcare physician or nurses during treatment with Phesgo. If we talk about healthcare physician's point of view, then there was definite decrease in drug preparation time as well as treatment room time. So more vigilant and economic use of sources, whether it is hospital's resources or health or hospital staff. So more than 80% of the healthcare physicians thought that Phesgo was the quickest form of preparation and it required less resource usage. And also there was less drug wastage because it is a fixed dose combination and decreased chances of error of dose calculation. Even AE rates after and before switching were similar with new safety signals in this study. According to Francesca study, 85% of the patients preferred Phesgo over IV pertuzumab plus trastuzumab combination. Main reasons were less time in clinic and more comfort during administration. And from healthcare perspective, definitely there was marked savings in time as well as resources of healthcare setting. There were no new safety signals. It was tolerated very well. Even after switching from IV to sub-Q, we can comfortably switch the patients from IV to sub-Q formulations or vice versa. Important point to be noted for practice that we should maintain adequate privacy during administration. Either patient should be given a single room or should maintain proper curtain and privacy. We should counsel the patient, and we have to watch the patient for 30 minutes after loading dose and approximately 10 to 15 minutes after the maintenance dose of Phesgo. Just a crux that what benefits Phesgo provides in cost, time and reduction of healthcare of physician and patient burden. There is short administration time of 5 to 8 minutes and observation period of 15 to 30 minutes of Phesgo, which reduces the burden on patients, carers and providers, as you have discussed in the previous slides. It is again a less invasive administration, single sub-Q injection. So we can think that after surgery in adjuvant setting, patient has no venous access. There is no need of port or PICC lines. You have to just give a single sub-Q injection in 5 to 10 minutes and patient is done. An observation of period of 10 to 15 minutes. Fixed dose formulation again decreases the chances of errors, decrease drug wastage and increase availability of staff for other tasks. Again, we have reduced time required for drug preparation and administration, which decrease the strain on infusion centers, and no new safety signals have been observed, which was a concern with many healthcare professionals and also most importantly with the patient. So with this data, we can counsel our patients that even switching from IV to sub-Q Phesgo is safe and it has same efficacy. Overall summarize, Phesgo is the first formulation in oncology to combine two MABs, that is pertuzumab and trastuzumab in 1 vial of sub-Q injection, and offers a faster and less invasive method of administration compared to IVPH. Phesgo pharmacokinetic data and incidence of adverse events comparable to those with IVPH combination, even when switching formulations. PET-CR rates were almost identical between sub-Q and IV arms of pertuzumab and trastuzumab combination in intent to treat population. Majority of the patients preferred Phesgo versus IV pertuzumab and trastuzumab regardless of sequencing, and felt that Phesgo had no impact on patient and healthcare physician speaking time. More than 85% of healthcare physicians also thought that switching from IV to sub-Q injections would save time and resources, and also preparation and treatment time. And also Phesgo is now FDA and EMA approved for same indications as IV pertuzumab and trastuzumab, that is HER2 positive EBC as well as MBC with or without concomitant IV chemotherapy. Thank you very much.
Thank you, Dr. Hitesh. Definitely, Phesgo has changed and turned the table regarding the HER2 positive breast cancer gamete. And I think we have used a couple of patients, and initial the apprehension regarding that 20 ml subcutaneous administration, it would be very it may be difficult for nursing staff. But we have used in a couple of the patients, and there is no such administrative glitches as of now. So
Absolutely.
What is your take on regarding
Yeah,
that?
absolutely. Even we had apprehension while using it for the first couple of our patients, but with using in more and more number of patients and more cycles, we as well as our staff, and even in fact the patients are also very confident now. So in fact they also insist that definitely we need to switch to sub-Q rather than IV in most of our patients.
All right. So now we are moving towards another molecule, that is TDM in HER2 positive breast cancer. And we have seen that the TDM has also turned the table, like in Hodgkin lymphoma, the response guided therapy. So like in Hodgkin lymphoma, 2 cycle of ABVD, then we do the PET scan and then escalate, de-escalate or change the therapy. So like in a HER2 positive breast cancer, there is a drug, there is TDM, according to the histopathology report, we can change the therapy. So for that, our new speaker, Dr. Shivam Singla, he's a consultant medical oncologist from SL Raheja Fortis Hospital, Mumbai, and he will be talking about HER2 positive EBC, how TDM can help. And this session is sponsored by Zydus. So over to you, Dr. Shivam.
Thank you, Dr. Hitesh and Dr. Gurang, for such an interesting conference that you have organized. I would also like to thank Zydus for giving this opportunity to me to present, their point of view on HER2 positive space. What I've seen in my practice is that HER2 positive space is becoming as good as mutation-driven lung cancer. Breast cancer is just becoming similar to that, and it is so exciting when I get a HER2 positive breast cancer patient. I am very happy. Initially I used to be sad that what will I do with such a patient. Now I'm very happy that such patient is likely to do better, and I will have a lot of options to treat, especially in the era of generics. So is my screen visible?
Yes, yes, yes.
So when we look at the prognosis of a HER2 positive breast cancer, this is a Norwegian study, but we have always known that HER2 positive cancer does the best outcome is in luminal B, then basal, then a HER2 positive. Without HER2 blockade, this cancer spreads faster, kills the patient faster. And there's a strong correlation between the poor clinical outcome and the amplification of a HER2. Even the depth of HER2 amplification is related to the response of HER2 directed agents, and this also leads to a poor outcome. When I talk about HER2 amplification, it's a surface receptor. You have two types of receptors, basically HER2 and HER3, and this leads to a downstream pathway which activates the PI3K-mTOR pathway. Now, since the onset of 1998, we have had a lot of agents to target this molecule. One was a trastuzumab, FDA approved in 1998, game changer in breast cancer, both in the NSCT and the adjuvant settings. Then came a plethora of drugs, including pertuzumab 2012, lapatinib, some interest in brain metastasis, neratinib in 2017. We are still awaiting this beautiful drug to be available in India. Tucatinib, again, small molecule not available in India. But on the other side, you have conjugated molecules like TDM1 and TDX1, which are changing the way we look at HER2 positive breast cancer. So the space in HER2 has exploded. And when I look at the future molecules which are coming up, it is even more exciting. When we started with trastuzumab, there were three basic big trials which stated that using trastuzumab in an adjuvant setting improves both DFS and overall survival. These are the three major trials for HERA, NACBP B31, and BIC006. Now, all these trials looked at removing, improving the OS, and also looked at removing anthracycline as one of the drugs in a low risk HER2 positive breast cancer. When you look at the DFS and OS, both of these trials, all the three trials had a good delta. In a HERA trial, the OS delta was 6.5, which was much higher than what we get in a hormone positive breast cancer delta. In a NACBP B31, the delta was even 9%. And in a BRIC trial, the delta was 4.6% if the TCH was used as compared to anthracycline. But risk of recurrence still needed to be minimized, and there were plethora of newer agents coming up. So we tried to identify which are the factors which are leading to higher risk of recurrence. Whether it was age, no, there was no difference. The major implications were found to be on three basic factors. The tumor size of T2, T4, they were recurring more as compared to the tumor size 1, a node positive disease as compared to a node negative disease, and a hormone positive disease as compared to a hormone negative disease. It is also important to understand that the grade in a HER2 positive cancer does not matter, because all these cancers are considered to be a high grade disease. When you look at what are the current guidelines which patients should be considered for the neoadjuvant therapy, I think in a HER2 positive disease, it is very clear, wherever applicable, try to give neoadjuvant therapy as compared to the other therapies, because that suits the dictum of the plethora of agents and options that we have. When we look at the current options for HER2 suitable candidates for neoadjuvant therapy, these are the patients with inoperable breast cancers, all inoperable breast cancers, but also operable breast cancers which are more than T1C. These are the patients who have a high risk of disease. This should be offered neoadjuvant therapies. So in patients where you want to do a breast conservative surgery, such candidates are applicable for neoadjuvant therapy, and all patients of HER2 positive disease should be considered for neoadjuvant therapy if greater than T1C. Adjuvant therapy, I've already showed you that adjuvant therapy with trastuzumab has been proven to be beneficial. Let's look at beyond it. So patients who have any residual disease after neoadjuvant HER2-based therapy are also candidates for adjuvant therapy because they have a recurrence of up to 10%. And patients who have had a surgery first and no neoadjuvant therapy, if they are node positive or a tumor more than 3 or T4, they are ideal for HER2-based adjuvant therapy. This is what we know is because patients with low CR, PATH CR, who do not achieve a PATH CR, they have a poor event-free survival and overall survival as compared to patients who achieve a PATH CR. So there is a need for escalation of therapy in spite of using trastuzumab in the neoadjuvant therapy in the patients who do not achieve a pathological CR. Because you can see that the delta is quite a lot when we do not address these patients, for the adjuvant treatment. So what are the adjuvant therapies available as an option? So one of the options available is TDM1. This is a drug which is, FDA approved as an adjuvant therapy for an EBC and a residual invasive disease after neoadjuvant taxane and trastuzumab-based therapy. So if you have used a trastuzumab before, you have a residual disease, you have to offer the best agent to this patient because this patient has a more than 10% risk of recurrence. If you have used trastuzumab, pertuzumab in a neoadjuvant setting, or the patient is node positive or more than T2, you must offer them pertuzumab, trastuzumab for a total of 14 cycles. When you have used any therapy and you have a residual disease, then you can offer these patients extended niraparib. This was approved by FDA in July 2017. So last few slides which I'm going to show the data. One of was the Catherine trial. This is a trial which looked at randomizing patients for adjuvant TDM1 or trastuzumab in patients who had residual invasive breast cancer. These patients are anyways candidate for an adjuvant trastuzumab for 1 year. But this trial, the investigators said that if you use a better molecule, thus the recurrence goes down. And if the patient did not tolerate TDM1, they were offered trastuzumab completion to complete 14 cycles. When you look at the characteristics, risk stratification, the trial was well stratified in terms of ER positive, ER negative, operable, inoperable, other agents received versus trastuzumab received, node positive versus node negative. A huge trial, 743 patients in each arm, and a very big trial. So this is even the patients received trastuzumab and pertuzumab before the treatment. Still, in the Catherine trial, the investigators found that there was a delta in the event-free survival of 11%. Now, when you are looking at overall survival in a cancer like breast cancer, event-free survival is considered as or relapse-free survival is considered as a surrogate for overall survival, because the overall survival data takes a lot of time to mature. So when we looked at the number of events, there was a delta of 11%, and there was a 50% risk of reduction in the breast cancer with the p-value, which was significant in patients who were given TDM1 versus trastuzumab. TDM1 not only reduced the chances of distance recurrence, but also reduced the chances of local recurrence and the recurrence in the contralateral breast. When we look at the subgroup, it benefited almost entirely all the subgroups, but specifically patients who were node positive in spite of giving chemotherapy. These were all high-risk patients, specifically patients who were hormone receptor positive, and specifically patients who had received either trastuzumab or trastuzumab plus other agents prior to surgery. These patients benefited much better, and this was seen all across the group that TDM1 is now considered as standard of care in an adjuvant setting in all patients. So when you look at the secondary endpoints, there is a delta of 6.7% in the distance recurrence, and this is maintained at 3 years. The overall survival data is still maturing, and as I said, in a breast cancer patient, this patient should survive for a long period of time. It is very difficult to obtain an OS data in a short span of time. It may take about 10, 15 years, or maybe at least 10 years to develop such a data. Let's look at the other two trials. One was the affinity trial, which looked at pertuzumab randomization with trastuzumab as compared to trastuzumab alone. And this is a well-known practice in patients with node positive or a T54 disease to give them pertuzumab plus trastuzumab for a year versus trastuzumab alone, 10-year follow-up. It showed that the maximum benefit is there in the node-positive patients, and this is what the indication is that it is approved for today in the practice. And then you have niratinib data. The niratinib at 240 mg per day, slightly toxic drug in patients who are node positive. Again, the delta is about 5 to 7% in patients who have not received a PAT-CR. So again, all these things indicating that the 2 positive space today, patients who do not receive a PAT-CR, they are the candidates for adjuvant therapy, and we must offer adjuvant therapy today. So final few slides, when you look at the options available today for patients in India, you have TDM1, pertuzumab, niratinib. Pertuzumab, high cost, no biosimilar available. Niratinib, high cost, no generic available. We have a biosimilar available for TDM1. And as my colleague was also telling us that today in the breast, when we look at, we must look at these patients in a different spectrum. This is a complex algorithm, and patients who do not receive PAT-CR should receive a TDM1. We must have to make sure that our individual patients receive the maximum benefit. This is something we all oncologists practice today in our practice. So this is my last slide. Development of a TDM1 biosimilar has been a journey which I think Zydus has taken over a period of years and years of work and experience. In terms of totality of evidence, there is an evidence to support that the structure, function, human PK, human PD, clinical safety, efficacy, immunogenicity, and pharmacovigilance. The direct comparison of Ujvira versus the reference product is found to be highly similar. It is proven that more than 25% assays and 36 months of stability testing that today Ujvira is not only non-inferior, it is also the preferred drug in terms of the cost, and the overall survival data is shown that it is highly efficacious. And this is based on this that the DGCI, which generally doesn't grant permissions quite easily, granted Ujvira an approval in EBC and both NDC. So my last slide is that again, I have already shared this for patients with HER2 positive disease, breast cancer. There is availability of a lot of agents who have improved overall survival. We still need to offer new adjuvant treatments because these patients may be high risk after the surgery, and we may be a candidate for TDM1 based treatment. TDM1 as an adjuvant therapy for patients, for all patients who have not achieved a PAT-CR, especially for node positive patients. If you have used a dual HER2 agent before, try to offer these patients a continuation of trastuzumab and pertuzumab and extended niratinib if available for patients who have not achieved a PAT-CR is a good option. Thank you so much. With this, I would like to end my presentation and would like to thank the organizers for giving this opportunity to me.
Thank you, Dr. Shivam. You have rightly said that TDM has gained the momentum from second line metastatic setting to first line metastatic setting, and now in adjuvant setting according to the pathological response rate. But just one question I want to ask you that are you able to use a full dose of TDM, or have you encountered such problem regarding side effects?
So thrombocytopenia is one which I encounter quite frequently, and loose motions. So whenever you get thrombocytopenia, then the interval increase and dose reduction is mandatory. So with the biosimilar, there is some incidence of thrombocytopenia, but the drug is fairly well tolerable. I am able to complete a treatment in majority of my patients in the adjuvant setting. Sir.
All right. So now we will move towards our first panel discussion, that is regarding HER2 positive metastatic breast cancer. And for that, I would like to invite Dr. Mehboob Basade sir. He is a professor of medical oncology in Jaslok Hospital, Mumbai. And for that session, I would like to invite my panelist, Dr. Akash Shah from Ahmedabad, is a consultant medical oncologist from Apollo Hospital. Dr. Kartikeya Jain from Baroda is a consultant medical oncologist for Sri Himalaya Cancer Hospital from Baroda. Dr. Palak Bhatt, he is a consultant at Oncovin Cancer Center from Ahmedabad. Dr. Satyam Satyarth from Nagpur. Is a consultant medical oncologist from American Oncology Institute, Nagpur. I think Dr. Manan is not there. Dr. Jagruti Koladia from Ahmedabad is a consultant radiation oncologist from GCRI. And Dr. Priyanka Patel from Surat, and he's a consultant medical oncologist. So over to you, sir.
Hi, good evening, and thank you. Thank you, Hitesh, and your team for inviting. Hope you are able to hear me.
Yes, sir.
Yes, sir, you are audible.
Yeah. So I will just present my slides where they are.
Sir, just for your information, Dr. Satyam and Dr. Manan have not joined yet. And
Okay.
we have all the other doctors. We have 5 medical oncologists and 1 radiation oncologist in your
One
all-
radiation oncologist. No surgeon here, right?
Yeah, no, sir.
Okay.
We have Dr. DJ Vijay. He's for the next panel. So if he's available.
He is available. Yeah. Hitesh, one second. Just want to present my slides. Are you able to see now my slides?
Yes, yes, yes.
Okay. So let's go ahead. This will be a case-based discussion, and this is actually a live case of mine, and how we manage and how the other at the other institution this patient can get managed. That's what we can discuss over here. Here is a 72-year-old lady. She is postmenopausal, no family history of any malignancy, no cardiac problems or diabetes, hypertension. Actually, she came because of her one of the close friend got the breast cancer. So then she came to us, and she had already noticed the lump, but she was hesitant to show to the family and tell the family because last 2 weeks it has increased. So that's where she came in. On clinical examination, she had a 3 centimeter mildly tender mass, which was palpable in the left breast. Left perialar skin thickening was seen. Left axillary lymph nodes and the left supraclavicular lymph node was also present. Okay. So let me ask the all the panelists. Let me start with the Akash. Akash, how many of your patients of breast cancer present in the early stage?
It's almost now, I would say, 50% will be early stage, 50 to 60%, and otherwise in metastatic setting.
Okay. I mean, de novo metastatic? I mean, upfront presentation as metastatic disease, not treated earlier, like that. How many?
Yes, sir. Means two-third will be early stage and 1/3 will be de novo metastatic.
1/3 will
Yes.
be de novo. Karthike?
Yes.
Karthike joined. Palak?
Yeah.
Yeah.
Yeah. Am I audible?
Yes, yes.
Yeah. In my patients, sir, mostly 30 to 40% they are of the early stage, and rest are of the locally advanced or the metastatic stage.
Okay. Okay. So there is a little difference, probably where you practice also make difference. Palak?
Yes, sir. Approx 30 to 40% patient comes with early stage. Otherwise, locally advanced and metastatic settings, patients are higher.
Okay. In my setup, I see around 20% of the patients who are metastatic de novo. 80% are early. Out of that, around another 20% are locally advanced. So 60% would be, say, early breast cancer. 20 are around LABC and 20 are de novo metastatic. Anybody else? Jagruti, Priyank, you have any difference over there or same?
No, sir. More or less same. As
More or less.
yes.
More or less same. Okay. And obviously, how many of you straight away go for with the clinical diagnosis of breast cancer with the histopath for the other BRCA1/2 testing in the HER2 positive setting?
Only
Anyone
in-
can take it. Yeah, anyone
Only in
can.
younger patients, sir, only in premenopausal patients. Otherwise, in HER2, don't send BRCA, sir.
You don't send BRCA positive. Okay.
Sir, in usually like young patients, TNBC patients, and like less than 45, usually do
Okay.
BRCA1, BRCA2, or with a family
sta-
history. Family history.
Standard set guidelines everybody is using, like the TNBCs, younger patients, strong family history, all those things. HER2 positive and HR positive are the less if they are elderly and to get the BRCA positive. So in this patient, we did the mammography, and mammography showed there is a 3 centimeter mass in upper outer quadrant with periolar skin thickening. Left axillary lymph nodes were also there. On mammo also showed there was a right-sided breast mass, which they reported as a BIRADS 4A. So we performed the biopsy on the both the sides. Left-sided breast, it showed it's an infiltrating carcinoma grade 3, ERPR negative, HER2 3+, Ki67 was 25%, while on the right side breast, there was no disease. Has Satyam joined? No.
No, sir.
Okay. Yeah. Sorry.
No,
Is
sir.
this
No,
Satyam?
no.
No, not
No,
yet.
sir.
Okay.
No, sir. Yes.
So just indicate me, please, whenever he joins, so I can ask. Priyank,
Sure,
do you do any additional test other than what I have done over here in the histopathology, or any other thing over here in the investigations?
Workup, I would like to do PET CT scan in this patient further to
PET.
proceed.
Okay, the PET CT scan, you would like to get it done. Yes, okay. So I will show you the PET CT scan little later. Okay. That's the fairly standard that everybody gets the PET CT scan done, though NCCN doesn't recommend for all, but in India it is cheaper to do PET CT scan than the CT scan of different organs and different. So now you have a diagnosis of infiltrated carcinoma, which is 3 centimeter, ERPR negative, HER2 positive. So let me start with everybody. What is their choice? How many of you will send to the surgery, and how many of you will start with on the chemotherapy? Akash.
So we'll send to surgeon for it's a multidisciplinary team approach, but otherwise for all patients, neoadjuvant treatments.
Okay. No, you will discuss this patient in the MDT. That's fine. But
yes,
what will you start? You will start with the chemotherapy upfront, or ask the surgeon to operate?
neoadjuvant treatments, sir.
Neoadjuvant chemotherapy. Okay, Karthikeya?
Yes, sir. Same, sir. Same, sir. I will discuss in the
Any-
multidisciplinary and go with the neoadjuvant.
Anybody would like to go ahead with the surgery first in this case? Palak, Jagruti, Priyanka?
No, sir, I would like to go for NSCT first.
You will go with the NSCT. Okay, so now if you want to go ahead and give the NSCT, what is your choice? Anthracycline best or non-anthracycline best? Palak?
Sir, we can avoid anthracycline.
You can avoid. She's 72.
Yes, and we have now dual targeted agents as well for HER2, so we can avoid.
Okay. So what will be your protocol? What will you use?
I will go for TCHP regimen.
TCHP. Okay, great. Karthikeya?
Sir, in 72 years, we can go for weekly Taxane along with the trastuzumab and pertuzumab. Weekly
Okay.
nab-paclitaxel.
Weekly nab-paclitaxel.
Yeah.
Okay. Akash, let's discuss this once we get everybody.
It's a TCHP, sir. We can use
TCHP.
Taxane as a weekly or 3 weekly, depends on patient's condition, but it's TCHP.
Okay. So if you are going to use Taxane as a weekly, so will you prefer Dosi or Pacli?
Pacli, sir. Pacli.
Pacli. Weekly Pacli, or in TCHP, it is the docetaxel. That is what is used
Yes.
in the
yes.
protocol.
Yes, sir.
Okay. Jagruti, you are a radiation oncologist, or you give chemotherapy also?
Yes, sir.
Okay, what will be your protocol?
Sir, most like in this type of pest, they are started TCH protocol.
TCH, not P.
Yes, sir, TCH. If patient is affordable, then
Okay, if they're affordable, then TCHP. Priyanka?
Sir, I would like to go for TCHP if finance is not an issue.
Okay,
And I would also prefer weekly taxane in this particular patient because she's 72.
she's 72. Okay, so weekly taxane, that is weekly paclitaxel plus Perjeta plus trastuzumab. That's what every majority, and some are saying TCHP. That means I'm assuming it is probably the docetaxel and carboplatin what has been planned. Okay, so this patient had a PET CT scan, left breast, left axillary, and left suprachoroidal lymph nodes were positive. Right breast lesion was also seen in the PET scan, though the biopsy was negative. Their right axillary lymph nodes were also seen, and there were query lung nodules. Other parameters like ECG, creatinine, LFT, 2D echo were all normal. Okay, so as everybody said that they will go ahead with the chemotherapy and dual blockade with the HER2. And only thing I think Shivam just now said that tumors less than 2 centimeter, that is T1C, will go ahead with the surgery. Otherwise, everybody will go ahead with the neoadjuvant chemotherapy. So we started this patient on the TCHP protocol, and she received initially 3 cycles of docetaxel, carboplatin, trastuzumab, and Perjeta. And the trastuzumab and Perjeta was given as a Phesgo, which is a subcutaneous formulation. And patient tolerated well, very well, 3 weekly docetaxel, even at the age of 72. Don't get worried. Yes, we know the weakness, fatigue is quite common, but neutropenia and the platelet are not that much an issue. You can use the growth factors in such patients, and you can very well go ahead and give the docetaxel carboplatin. There is a drug interaction between carboplatin and trastuzumab, so it is better to use carboplatin with the NTCHP protocol rather than cyclophosphamide. There are some people use cyclophosphamide. Any one of you use cyclophosphamide in TCHP?
Not here negative patients.
Okay, not here. So this patient was given 3 cycles. How many of you complete the 6 cycles upfront? Akash?
All patients, sir.
All patients, okay.
All patients.
Anybody doing sandwich, a few cycles of chemotherapy, then surgery, and then anyone, Palak?
No, sir. We complete upfront 6 cycles.
All the 6 cycles.
Yeah.
Okay. Kartikeya?
Sir, all 6 cycles.
All 6 cycles. Okay. So this lady completed 6 cycles of TCHP, and you can see the scan. The lower down there, you can see the left axillary nodes, left cervical node, left suprachoroidal lymph node, and the left breast lesion. And after the 6th cycle, that is the topmost line where you are seeing the complete response radiologically on the PET scan. Now, this patient is planned for the surgery, and so this patient will go ahead with the surgery. One more thing which remaining, and that's where I was asking about the surgeon, that at what stage you will send the patient to the surgeon, apart from the port insertion, for the any clip insertion here will be done. The surgeon is there, right?
Yeah, this is Dr. Vijay. I am not part of the panel.
No, please comment on.
So that is the point that I was about to make, that if it's a unicentric disease at presentation, then probably we would have done a clip insertion upfront before starting the neoadjuvant chemotherapy, because there could be very exquisite responses to anti-HER2 therapy, and we would not wait for the response.
Agree, absolutely agree. And this patient was sent to the surgeon. He has clipped the primary lesion. So we know that if we get complete response, where was the primary, so that we can plan for the surgery accordingly, if she's willing for the mastectomy. Okay, will you do the breast conservative surgery in this patient who had this skin tethering, and you have the PET scan in front of you, left supraclavicular lymph node and other things?
Skin edema is a relative contraindication to doing breast conservation surgery.
Yeah.
If it was the tumor was close to the skin and just tethered, we might excise the overlying skin. So we have to be sure whether the edema is because of excessive nodal disease or thing. But we can, in the presence of very effective systemic therapies, I think this paradigm is also going to shift, and patients who have complete resolution of skin edema, some of them may be amenable to breast conservation surgery, sir.
Okay, no, great. I mean, we gave the option of breast conservative surgery to this patient, but she was reluctant. She said that jad se nikalo. That is what people say, that usko jad se hata do. So how many of you will offer the MRM upfront or the BCS? Akash?
No, sir, it's depends on, as Vijay sir said, if it is unicentric, and mostly as our patient 60, 70 plus patients, they don't prefer BCS and they suggest for MRM only. So for these patients, as I also didn't suggest for clip insertion upfront as locally advanced disease.
Okay, BCS versus MRM. What would have been your advice or patient choice? You are mute probably. Palak?
Yes, sir, we can go for MRM because patient wants to go for MRM unless she's young. Otherwise, they prefer to go for MRM.
Okay, Priyanka?
I would advise BCS to all my patients if it is feasible and patient wishes.
Okay, fair point. Jagruti?
Same, sir. If it depends on the patient choice. If patient is comfortable with BCS, then go for BCS. If patient is refused for BCS, then MRM is the only choice.
Then the MRM. Kartike, what percentage of the patient you expect PAT-CR in this situation where you have given dual blockade?
Sir, it's around 60 to 70%.
60% of the patient.
Sir, I will offer the patient both BCS as well as MRM because both have the same survival benefit. Whatever the patient thinks, she can go with that.
No, it was the only thing was that skin involvement. That was the only issue. Otherwise, both options are there. Though the skin was clinically, there was an edema in scan, and on the mammography, the skin was not involved. So she had an option of breast conservative surgery, but she preferred, in our case, she preferred the complete mastectomy. So we did the MRM for this patient. And the histopathology report suggested a complete pathological CR, both into the axillary nodes, left supraclavicular lymph node, and the breast tissue. I just wanted to ask surgeon, will you go ahead and do the left supraclavicular lymph node dissection also? Because in this case, it was positive.
If it was positive preoperatively,
you can see the scan, PET scan here, down on the left side, the last, you can see the left supraclavicular lymph. Yeah, Dr. Vijay, we can't hear you. Priyanka, you want to add?
Sir, I would like to, we will definitely do pre-op workup in the form of, in this particular patient, we can do repeat the scan and then we can see.
Scan is there, no, the PET scan is there. It has showed complete response. You can see all three PET scans.
Can cover the left supraclavicular lymph nodal area in the radiation post-surgery. No need to
So
dissect.
mostly if pre-operative post-neoadjuvant, if it disappears, surgeons don't dissect supraclavicular region, and anyways it will be covered in radiotherapy. But if there is any like 1 centimeter query lymph node is there, then it will be dissected. So.
Okay, Dr. Vijay. Yeah,
Conventionally, we do not do supraclavicular lymph node dissection if the PET CT scan is
is negative.
If the PET CT scan is showing complete response, then we would probably not do a supraclavicular lymph node dissection, and we would anyway include it in the radiation field.
Okay, okay, that's fine. Jagruti, you are a radiation oncologist. How do you do? You see that the removal of that lymph node is okay, or you will like to irradiate irrespective?
Sir, we have to irradiate that supraclavicular region.
You have to irradiate, okay. And as surgeon
Uh,
said that.
Sir, we can ask Jagruti madam reversely that how many patients she is seeing that supraclavicular lymph node dissection are done during when she sees for radiotherapy, adjuvant radiotherapy.
So this kind of node which is seen is rare. It's not very oftenly seen.
Yes.
Where patient is receiving neoadjuvant chemotherapy and other things.
Yes.
So the numbers obviously will be small, but yes, in radiation part also they try to include the supraclavicular area so that that their recurrences are less. That's why patients complain of swallowing difficulty most of the time when they complete the radiation.
Yes, sir.
So how many of you have used similar TCHP with H and P, the trastuzumab and the pertuzumab as a Phesgo, as a subcutaneous preparation? Priyanka, you're mute.
I've used Phesgo in one patient, sir, as of now.
How has been your experience?
So I've used patient with metastatic breast cancer, fungating breast mass with multiple liver metastasis. She has received weekly weekly paclitaxel plus carboplatin plus Phesgo. As of now, she had just before few days, she had received her 10th dose of Phesgo, and she is in metabolic CR as of now.
Okay. Anybody else want to add? Experience with the Phesgo. I have used in 7 patients, both in early breast cancer as well as in metastatic. And metastatic patients have completed more than 15 to 16 cycles, so practically more than a year. And experience has been really good, except in one patient. Loose motions are quite common with the Perjeta, and which has remained there even with the Phesgo. But otherwise, if you ask, patients prefer the Phesgo over the IV preparation because the duration of the treatment has come down.
Yes, sir.
Okay. The one more thing is that in this patient now we have given the neoadjuvant TCHP, surgery done, PAT-CR in the histopathology. What would be the next line of? She is ERPR negative. Radiation is planned. She is receiving radiation. Okay. So what would be your plan as far as an adjuvant anti-HER2 therapy is concerned? Let me start with Akash. You will give dual blockade now here or single trastuzumab?
Dual blockade, sir, for 1 year.
Dual blockade for 1 year. Okay, Karthikeya?
So same, sir, dual blockade for 1 year.
Palak?
Yes, sir, same. To complete 1 year of dual blockade.
Why not just to give trastuzumab? You have a data. This is here now PAT-CR. There is
alone.
Yeah.
Because patient is having complete metabolic response. I would like to discuss the risk benefit and the benefit of giving dual blockade in adjuvant treatment, which is very less as per the adjuvant Perjeta trial. So, and this patient is having metabolic CR. So I would like to discuss
not only metabolic, pathological CR.
This patient is having pathological CR.
Yeah.
So I would like to discuss and maybe continue with trastuzumab alone.
Okay. Jagruti? Can't hear you. Has Satyam joined?
No, sir.
No, sir. Okay. So let's go ahead. We all know that those patients of the HER2, and just now Shivam was mentioning same these trials, those who achieve PAT-CR, there is a very high chance of these patients of living longer as compared to those patients who do not achieve PAT-CR. And if suppose she would not have achieved PAT-CR, then what would have been your plan of therapy? Any change in the plan? Priyanka?
Then we are stuck, sir. What to do? We can give TDM1, we can give dual blockade, or we can continue with trastuzumab with finances and all.
Okay. Okay.
That are still debatable issues, I think.
Yeah. But, TCHP, if you give, and if there is a residual disease, the data is in support to give TDM1. So you can go ahead and give the remaining adjuvant with the TDM1. Akash, what will you do?
Sir, TDM1, sir.
TDM1. Kartikeya?
The TDM1.
Okay. Anybody else? Jagruti, are you joined back?
Yes, sir.
Yeah.
Is a residual disease, then TDM1.
TDM1. And just now there was a discussion regarding toxicity of TDM1. I had a patient who had completed 5 years of TDM1 in metastatic situation. Remember that liver toxicity is quite common. This patient ultimately developed liver cirrhosis, and she died because of liver cirrhosis, not because of the disease. So we all the time monitor only 2D echo, 2D echo, 2D echo. But remember that the hepatotoxicity is quite common with the patients with the TDM1, and always look for the liver toxicity. That's also very important. Any comments on that? Have you seen, any one of you have seen the hepatotoxicity of TDM1? No. Okay. So majority of the guidelines now suggest that use dual blockade upfront in the patients who are more than T2 or node positive. And that has been the standard, including NCCN, St. Gallen, German AGO, and the European ISMO trials also. So again, every patient will get discussed. And the other thing, I think there are not many things which are remaining. The only thing is that regarding the FESGO, the subcutaneous preparation, the patient preference is important. And if you look at the data from the two trials, one trial is what we call as a Federica trial, where they have looked at the pharmacokinetic and efficacy and safety of fixed dose, the subcutaneous version of Perjeta and trastuzumab versus an IV, and there is no difference, both are same. And as far as patient preference is concerned, patient always prefer the subcutaneous. So I have one trial which is going on, which will be starting now, where in the same situation what we have done just now, the patient will be given the trastuzumab and the Perjeta free as far as part of a trial can go on the subcutaneous version, and it will be given at home, not in the hospital. So how many of you have you ever thought of giving the FESGO at home? Are you comfortable first? I mean, honestly speaking, I'm not comfortable in asking the patient, but this is a part of trial. So we are doing it to know exactly what's happening. How many of you will be comfortable? Priyanka, you are nodding, saying no.
No.
No. Okay. Akash?
No, sir.
No. But let me tell you, whatever 7 patients and number of cycles might have been almost, I would say, around 40 for all these patients. And we haven't had any toxicity with the subcutaneous version. Only thing is that it takes 5 to 10 minutes of the duration of the injection, which has to go to subcutaneous. That is the only thing. Otherwise, there are no toxicity. And let's look at this trial once it gets published, whether patient's preference at home is how it is and how it can be managed. I think we discussed all and we are well within the time. If anybody wants to add something or comment on something, then we can. Otherwise, we will hand over to Gaurav. I can see him moving.
Sir, if any panelists don't want to any comments, so sir, one question from my side is that, sir, there is a HER2 low disease is buzzing around the medical fraternity, and the one school of thought is saying that it's not a clear-cut entity, and one school of thought is saying that there is a clear-cut entity, and there is a robust data of TDXD available. And I am
Yes.
sure that within 3 to 4 year or 5 year down the line, we can have in India TDXD. So right now, sir, how do you take HER2 low disease?
I mean, as you rightly said that the TDXT is not available in India at present, so there is no change in our management of HER2 low. We treat it the same as like we other patients. But yes, what I feel that rather than that HER2 pathway, probably the chemotherapy component in TDXD is probably a good. That's where the effects are much better. The trastuzumab we are already giving for all the patients, but we are not seeing such kind of results in the HER2 low disease because it's a trastuzumab plus the chemotherapy component. That is that's where the TDXD is there. But yes, yeah, there is a data even in lung cancer in HER2 positive showing good response of the TDXD. So one has to accept the data and go ahead with that.
Yes, sir.
Okay,
Okay.
thank you, panelists, and thank you, Rosh, and thank you, Hitesh, for inviting all of us over here. Let me stop sharing my slides, and we will go ahead. And,
Thank you, sir.
Thank you, sir.
Thank you very much.
Thank you.
Thank you.
Okay, so from HER2 positive era, like we have discussed TDXD, TDM1, and FESGO, and a panel discussion regarding the HER2. Now we are moving towards one of the most important topic, that is high risk disease, TNBC, triple negative breast cancer. And for that, I would like to invite Dr. Vamsi Krishna. He is a consultant medical oncologist and HOD director at AIG Hospital, Hyderabad. And this session is sponsored by AstraZeneca, and he will be talking regarding the redefining the management of HER2 negative early breast cancer. So over to you, Dr. Vamsi.
Good evening, and thanks, Dr. Hitesh, for calling me, and thanks to AstraZeneca for sponsoring this. Just give me a second, and I will load the slides. So okay, so I am assuming that I'm audible and my slides are visible.
Yes.
Okay,
Please.
great.
Yes, sir.
Great. So what I will do in the next 20 minutes or so is talk about HER2 negative EBC. Now, as we will see, EBC doesn't mean exactly only very, very early tumors, and I'm not going to talk about chemo and other things. My session will focus on the BRCA, the role of BRCA, and how we target the BRCA in early breast cancers. So we do know that a lot of people will have a TNBC, and among these patients, the tumor chances of recurrence is higher. 9% of these patients would have a germline BRCA. Now, this is data from 2020, where they showed that 30% of patients actually have early breast cancer at diagnosis. If they are higher, then possibly the results would be slightly better. But again, this is something we are aware of, that more than 57% would actually present with a loco-regional disease, and less number would present with early disease. Now, in a nutshell, a huge complicated looking chart, which I'm calling a nutshell. I'm not going to focus on all of this because, like I said, my talk is not going to be about the chemo, the neoadjuvant, and so on. I will talk upon the changing landscape of the HER2 negative early breast cancer, specifically in terms of the BRCA mutations and the role of PARP inhibitors in this BRCA mutation. So we do have Keynote 2522, we have the IMpassion031, we have Monarchy, we have Palace. All these are there in HER2 negative EBCs. But one subset is the BRCA mutant disease. Now, patients with BRCA mutant EBCs have distinct characteristics. They are diagnosed at a younger age. They're typically of a higher grade. They usually have a more aggressive phenotype. They have more CNS metastasis, and they do present with more contralateral or ipsilateral disease. Now, out of the total population, it is estimated that around 5 to 25% of patients would have a BRCA mutations. These mutations are more prevalent in TNBC than HR positive breast cancer. But please remember that germline BRCA is also seen in HR positive disease. So this is just one kind of a just a informatic, which shows you that among patients who have HR positive disease, still a significant proportion will have germline BRCA, a smaller proportion has somatic BRCA. Whereas for those patients who are TNBC, again, a significant proportion have germline BRCA and a small proportion have somatic BRCA. Right now, today for the topic, we would be talking mostly of the germline BRCA. Now, in India, there have been some studies which have come around, and by and large, what has been seen is that the prevalence of pathogenic mutations is higher in India in comparison. So one of the studies showed that the prevalence of pathogenic mutations was higher in Indian patients. One study showed around a mutation frequency of 13 to 15%. And a Tata study, large study, also showed a similar result of roughly around 15 to 20% of BRCA mutations. So how does this knowledge help us? Number one, of course, when it comes down to later, when we can talk of olaparib, early knowing BRCA status would help in the surgical decision, especially when it comes to mastectomy and, more importantly, contralateral prophylactic mastectomy. There was a study which showed that in those patients where we knew the BRCA status prior to surgery, the number of contralateral prophylactic mastectomies were around 76%, much, much higher than in those patients where the BRCA was unknown prior to surgery. So that's what BRCA would impact prior to surgery. What about later? And this is where the Olympia study was conducted. Now, the basic idea behind a PARP inhibitor is not something I'm going into today. Essentially, a PARP inhibitor utilizes the synthetic lethality present in BRCA mutated tumors and will inhibit the PARP that will not allow DNA repair. And this idea has been tested in prostate, it has been tested in ovaries. One of the studies that tested it in adjuvant breast cancer was the Olympia study. Phase 3 study, olaparib versus placebo as adjuvant therapy for high-risk germline BRCA, HER2 negative. Now, very important criteria, which we need to remember. It was only germline pathogen, right? Very, very important. Just because we have HRD panel testing for ovary does not mean we should do it in breast. Just because we have a so-called HRR panel in prostate or in breast, do not do it in breast. Remember, the Olympia study very clearly was only and only germline pathogen. They utilized stage 2 and stage 3. So anything T3, any N positive would go into the study. Now, these patients had to be HER2 negative. They could be HR positive or TNBC. Again, something you need to remember. Just because Olympia is about PARP inhibitors, it is not exclusively TNBC. They included both the groups. Now, the patient should have completed local therapy, should have completed 6 or more cycles of neoadjuvant or adjuvant chemotherapy. So there were 2 groups which they included. Again, very important. Just because a patient is stage 2, stage 3 BRCA mutant, patient will not go into this trial. The criteria were rather stringent. Now, if the patient had a TNBC, received neoadjuvant chemotherapy and achieved a PAT-CR, they would not be eligible. The patients had to have a non-PAT-CR. If they were receiving neoadjuvant therapy and they were HR positive, along with non-PAT-CR, they should have also had the CPS-EG score more than 3. So this is what I would be elucidating in the next slide. Now, in the adjuvant group, means you did your surgery upfront. There, if you had a pathological T2 or a pathological N1, you could be included in the study with a mutant BRCA. So just to throw off a case, a patient comes, you operate, it turns out to be T2N0 and a BRCA mutant, they're eligible for this study. But if a patient has upfront come with a street with any tumor size and they have been given neoadjuvant chemotherapy and they do not achieve PAT-CR for a TNBC, they're eligible for the study. Okay, so that's how we remember. 2 things to remember, again, I'm highlighting germline pathogenic BRCA and BRCA2. And number 2, a T1 upfront will not go into the study. You need to fulfill these criteria. For HR positive, if patient has an adjuvant therapy, more than 4 positive lymph nodes. Now, a HR positive group with more than 4 positive lymph nodes, as all my listeners will also remember, is one of the criteria for your adjuvant CDK inhibitors. So this discussion of how you would put your CDK4 inhibitor along with the olaparib is something we need to remember. All patients could get radiation as per schedule. You had to have olaparib at the standard dose, 300 milligram twice a day. Big population, 1800 patients. Primary endpoints, IDFS. Key secondary endpoints, DDFS, OS, and BRCA1-2 associated cancers. Now, again, this is something that we do talk of, that should we always have a IDFS, but remember the STEEP criteria in 2005, it kind of clearly established that if you have IDFS, that's pretty acceptable as a surrogate marker. So almost all our trials are using IDFS, and that's fine. Now, this is the high risk criteria. TNBC were actually 80% of the patients. Now, these patients were required to have axillary positive disease or at least 2 centimeter disease. If neoadjuvant, no Paxia. HR positive, remember they were only 18% of this, but this was what they were required. They were needed to have 4 positive lymph nodes or a CPS EG score of 3 or higher. Now, this is the CPS EG score. And frankly, I don't usually do it, but if I have a HR positive where I'm doing BRCA, then I need to do this score if I'm given the neoadjuvant. Essentially looking at stage 3A, 3B, 3C, pathological stage, clinical stage, receptor status, and a nuclear grade. Remember, this is nuclear grade. This is not the total grade. This is the nuclear grade. So when you look at the report, look at nuclear grade and not the total grade. This is not grade 3. This is nuclear grade 3, which is part of the BR staging. So this is something we need to remember. Again, 10% of patients, but this is something we might forget. Nobody can remember this. Obviously, we need to keep looking at the paper. Now, patients with higher score relapse earlier. That's the reason why the score has been used. There has been a meta-analysis where they showed that more and more the score increased. That's when the data went worse. So that's how they have applied this CPS EG score. Now, between the two arms, as usual, the characteristics are well defined. 70% BRCA1, 28% BRCA2. So this is again what we see. Remember, in prostate, you see mostly BRCA2. Ovary, again, BRCA1, BRCA2 are seen. Here, 70% BRCA1. Premenopausal 62, postmenopausal 37. Now, prior therapy in the form of neoadjuvant given in 50% of patients, adjuvant in 50% of patients. 94% got both anthracycline and taxane, and that's a very heartening thing because this is what we all do in practice. This is how we treat. We give neoanthracycline, we give the taxane, and that is what is reflected in the study. Now, HR positive were 18%, TNBC was 80%. So that's again kind of what we see. So 18% does translate into 168 patients, which is quite a sizable percentage. Now, in the final report, the risk of invasive recurrence or death was reduced significantly, hazard ratio 0.58, pretty decent confidence intervals, p-value very significant. More importantly, 3-year IDFS rate, a difference of 8.8%. For comparison's sake, the abemaciclib, which a lot of us accept, has an IDFS difference of around 4 to 5%. So here you're having 8.8%. So, the difference is rather significant. This was maintained even after one further year of follow-up. Again, the difference remained at 7.3%, slightly hazard ratios increasing to 0.63. Now, one thing is over 7% of patients, more patients treated with adjuvant olaparib were free of recurrence at 3 years. So again, this is a hazard ratio of 0.57 and the 3-year distant disease-free survival rate was around 7% difference. When that was followed up for one more year, the difference remained static at 7% and the numbers are slowly reducing. What about the OS benefit? 0.68, reaching the statistical significance with a confidence interval of 0.97. So, here the absolute difference becomes less. It's only 3.5%. But then again, it's something that we do expect that possibly when you go for a longer time, you're going to see this curve separating. Now, an interesting part is this difference is actually becoming apparent after 2 years. So that tells you that possibly the advantage of your olaparib is seen going later and later. This the difference starts increasing. What about incidence of second primary non-breast cancers? This was also halved in patients who received olaparib, as can be expected. Consistent difference seen across subgroups. Importantly, in the small subgroup of around 240 patients, in comparison to whole trial, that's pretty small. This difference was not statistically significant. You had a 0.791, but the confidence interval went up beyond unity. But aside from that, it showed a benefit in other arms. HR positive, again, the confidence interval crossed unity line, but it showed a clear difference in the TNBC arm. The difference was seen in BRCA1, BRCA2. The numbers are not too large. It showed, again, just crossing unity, but I'm not sure how significant this number is. For HR positive, crossing the midline did make a difference. For the TNBC, there was a definite improvement. What about OS? Again, we are seeing the same thing for HR positive and prior platinum, not so much. For adjuvant, not so much, but other places, you are getting the difference. So if you have not used platinums, you have a TNBC, definitely this improves. We are aware of the side effects of olaparib. More than 70% did complete according to protocol without a need for a dose reduction. Again, as we have become more used to the drug, we know how to use it, and we are aware that there are going to be patients who discontinue the drug. In the trial, it was only 10%. Mostly the AEs were mild and moderate, quite manageable. Serious AEs, MDS, AML, we are worried about it, but 2 and 3, that's possibly just statistical. It is not really a important number that I am worried about. What about the other trials? These adverse events were rather consistent. Blood transfusions, we do talk of them. Not too many people required a transfusion. And again, that number is quite reasonable, and we know how to maintain it. No change much in the PROs, not much change in the fatigue severity. Clinically meaningful difference was there in nausea, vomiting, but again, these are things we are aware of. And if I'm getting a difference of 7.7% for an IDFS, I think I can manage these side effects. They're not that debilitating, and they can be used. So again, summing up, olaparib in Olympia has taken its place among all these other drugs. We could argue about the context of the benefit, the absolute benefit, but then definitely this drug is one of them which has shown advantage in EBC, and that advantage is reflected both in the OS and the DFS. So now for HER2 negative, well, slightly better algorithm. In a TNBC BRCA mutant, you would give adjuvant olaparib for 1 year. If it is BRCA wild type, pembro, well, again, the jury is out. I would reserve my pembro for a neoadjuvant setting. Where would I place adjuvant capecitabine? Again, not much data whether this works in the BRCA mutant setting. Possibly, I would still prefer olaparib here rather than adjuvant, considering it's a targeted therapy. For a HER2 positive, you would give endocrine therapy for sure. Whether you can give Abima here or whether you want to give your olaparib and then add your Abima, again, is an open question. Because interestingly, in the Abima trial, they allowed Abima to be started 1.5 years after the surgery was done. So, you know, that's possibly a location where you can squeeze in your olaparib if you want it. So to conclude, Olympia is the first study to report the clinical benefits of olaparib as an adjuvant treatment. With more 9% more patients recurrence-free, 1 year adjuvant olaparib significantly reduced the risk of recurrence by around 42%. Adjuvant Lynparza also resulted in an overall survival with 32% reduction in the risk of death. Safety profile is pretty consistent. Testing for BRCA is essential to maximize our outcomes. So thank you, and back to the organizers.
Thank you, Dr. Vamsi. And now we'll move to our next panel discussion. That is target in triple negative breast cancer. And for that, I would like to invite Dr. T.P. Sahu. He needs no introduction. He's a consultant medical oncologist from Silver Line Hospital, Bhopal. And for that, I would like to invite esteemed panelist, Dr. Ankit Patel. He's a consultant medical oncologist from Surat. Dr. Vikas Asati from Indore. He's a consultant molecular oncologist from Sri Aurobindo Institute of Medical Science. And Dr. Siti Joshi, is a senior consultant molecular oncologist, Mumbai Oncocare. And Dr. Prasant Bagli from Bangalore. He's a practice head oncologist, Trend Science. I think Dr. Samir, Dr. Mansi, and Dr. Salil. Are you there? I think Dr. Salil, Dr. Mansi, and Dr. Samir are not there.
Okay.
So, sir, we can start.
Yeah. Thank you, Hitesh and Gaurang. Vamsi, you are there?
Dr. Mamsi, yes. Okay.
Vamsi, you are there? No. Okay. I just wanted to ask him whether the OS data is mature for the Olympia. That's all. Okay. Let's now go into the panel, and we have Ankit, we have Shitish, we have Vikas, and we have Dr. Prashant. And Dr. Prashant is a molecular person. Am I correct?
Yes, doctor.
Thank you. So let's jump into the things in next half an hour. We'll go into the targets in TNBC. So I'll start off with the case, and then we can jump into first the neoadjuvant setting very quickly, and then jump into the metastatic setting. And anyone who's there can just feel free to jump in if there is something which we're missing. So we have a 42-year-old female with a breast lump, no family history, T3N0. As we told with the previous panel that anything beyond 2 centimeters would go for a neoadjuvant. I assume that would be the case here also. Dr. Ankit, that has been your practice for TNBC? Dr. Ankit? Is Ankit there?
Yes, sir, Ankit is there, but I think he's...
Can someone just connect with him? Shitish, anything more than 2 centimeters quickly, and we move on.
Yes. In TNBC, definitely NSCT.
Okay, so anything more than 2 centimeters. So Vikas, for a neoadjuvant setting, if you assume that you are interested for immunotherapy, do you do any workup other than that the ER/PR HER2/neu, or any special thing you would like to do?
No, sir.
No,
only ER/PR HER2 Ki67.
Okay, so PDL1, CPS score, or TILs?
Like TIL comes with morphology, sir. Otherwise, specifically, like I'm not asking for TIL.
Shitish, what has been your practice? Any specific things?
Currently, so I am advising PDL1, but my majority 90-95% only ER/PR HER2.
So if you are advising, does it change your management? If it's a high PDL1, you would like to do a immune checkpoint inhibitors, and do you alter your treatment?
Currently, not yet.
Okay. So
but I would like to see.
Okay. So currently you are not modifying your treatment in the neoadjuvant as per a target. That's what thing that's coming up from both the panelists. Gaurang, just let me know when Ankit comes in, and if he's there, I can put him in. The TILs is something that we look into and gives a better prognostic marker and probable immune checkpoint. The long-term outcomes are better. That's the data. But as of now, we don't have a trial to tell us that if you do immune checkpoint in high PDL1, it does make a difference. So for this, both of you quickly, irrespective of the PDL1, Shitish, you would go for a immune checkpoint and a chemotherapy if money is not a concern?
Sir, Dr. Mansi has joined.
Okay, so I'll just bring her in. Shitish, so immune checkpoint and chemo?
So currently,
yeah. Shitish, please.
So currently, frankly speaking, I am using only chemotherapy as a neoadjuvant.
Okay, so
but I
if you have a financially
started
affordable patient, you would
definitely I will discuss.
Okay, so you are convinced with the data for immune checkpoints? Because same question. Are you convinced with the data for the neoadjuvant immune checkpoints?
Is this for me, sir?
Yeah, Vikas, for you.
Yes, sir. Yes, sir. If patient can afford, definitely, sir. I will add.
Okay. Mansi, yes, no. Convince for the data?
Yes.
And do you do PDL1 before you start immune checkpoint in neoadjuvant setting?
No, sir, I don't really check for PDL. I mean, that does not change, if I'm going to add immunotherapy or not.
Okay. So we just move on. This part of it was basically for 2-3 things because we're going to stick to the targets in TNBC. So the basic purpose that comes out in this, that is immune checkpoint in this setting influenced by PDL scores. If you look at the data from the keynote 522 and look at the right side of the PDL1 positive, the delta is around 14%. If you look at the PDL1 negative, the delta is numerically similar or little higher. Look at the IMPassion 031, the data really looks the similar way. So basically to tell us that we have not found the right biomarker at this point, if any, in the neoadjuvant setting, and all of us believe that neoadjuvant immunotherapy can be offered to patients in neoadjuvant setting in TNBC if the patient pocket can do that. Okay. Just a quick thing before I move on, Mansi, can you take this? If you are doing neoadjuvant immune checkpoints, would you be interested in adding anthracycline, or would you be just going off with a platinum taxane and not use anthracycline at all?
So in terms of the immunotherapy, I would use, the AC taxane platinum protocol. So 4 AC and weekly paclitaxel.
Okay, so there is some data to tell that probably anthracycline triggers the immune system and probably the responses and the PAT-CR could increase on that. So now we shift gears. This is something which I just wanted to highlight, that in the neoadjuvant setting, at least we do not have anything to tell on the PDL1. So now we go to the metastatic setting where we can find more targets. Dr. Prashant, I'll come down to you on this. We have a 42-year-old female presenting with breast lump, no family history. There are multiple liver and lung metastases. It's a TNBC, HER2/neu is 1, FISH negative. So to be specific, ER/PR negative, HER2/neu is 1, FISH negative. So Dr. Prashant, I'll come to you after the medical oncologists come in with their markers, and then you can tell us what exactly we are right or wrong on that part. So I'll start with Vikas. Because in such a case, as you told in the neoadjuvant, you would not do anything. So would you do something in such a case which are presented to you in the metastatic setting? Dr. Vikas.
Yes, sir. So I think here PDL1 is important, sir, in metastatic setting.
Okay.
So in metastatic setting, I will do so.
Okay, a PDL1 is one marker which you will do, a positive or any specific value?
So positive, basically, sir.
Okay. So apart from PDL1, anything else?
Yeah, so in BRCA 1 and 2, that also I will check.
You will do a BRCA. So you will do the PDL1 and the BRCA. Okay. Mansi, agree totally, partially, or you disagree?
So I think in terms of whatever is available in the market, immunotherapy and PARP inhibitors are the only agents that are available. We don't have.
No, apart from the availability, because I understand that point which you're making, assume that everything that is approved in the US is available in India.
So, I mean, then I think doing an NGS makes sense because we do have the AKT-P10 inhibitors, which are also approved in combination with chemotherapy for the metastatic setting. So I think I would just go with the entire NGS panel, in case if everything is available.
So you will look for PDL1, that's what you told and agreed to. BRCA 1 and 2, yes. And you would look for AKT, the P10 pathway, the mutations and the alterations. Anything specific you would also look in the NGS part? No? Okay, I'll come back to that. Shitish, anything you want to add to what Mansi has told? Assuming everything is available, PDL1, both of them agree. BRCA 1 and 2, both of them agree. She would go one step further into the NGS. She spoke of AKT, P10 pathway alterations. Anything more you would like to target?
So I agree with them. What is my current practice to do BRCA and PDL1 afferent if progression PIK3CA mutation, and if ready, NGS.
Okay. So,
Can I,
I will,
okay, sir,
yeah, please.
can I say something, sir?
Yeah, please go on.
Sir, there is a new variety of HER2 mutant non-amplified version is there. So I would like to see in NGS panel this kind of mutation as well.
The HER2 mutations.
Sir, HER2 mutant non-amplified. In those cases, there is a role of neratinib.
Okay, correct. So I like to hear on that after I finish this part of it, the data and how is it worth it. I'll kind of come down to Dr. Prashant. So everyone agreed that something is required. Point number one, there's a consensus on that, at least in the metastatic setting. BRCA 1 and 2, all of us agreed. The AKT is the PIK3 is something Mansi spoke about. The PTEN alteration, something she spoke about the ipatasertib, which is the drug that is there. We'll speak on the data for that also. I would like to have two things, Dr. Vikas, Dr. Prashant. Would you agree that when you do NGS, at least in the mutations and the genetic mutations, we need to look at something like the PALB2 and the other mutation that come along in the genetic parameters apart from BRCA 1 and 2?
Yes, doctor. So yesterday, I just because I was checking with the NCCN guideline, the absolute risk which they have studied. So in terms of the absolute risk now, apart from the BRCA 1 and 2, we also have the PALB2, even the RAD51C and RAD52, 51D, and some of those around 11 loci are also very important to be considered in the comprehensive genomic profiling, especially whenever there are the multiple cancers in the patient, doctor. And also, I would like to stress that if it is, again, like you rightly said, the affordability, I don't want to speak about that, but TMB status and the MSI status will really help in the overall survival of the patient, or rather the response to the therapies.
Okay. So you agree to that point, and we'll come to the PALB2. Is the data strong enough for us to also look at it? And as Mansi told, the NGS will pick this up, but we need to know what we need to be looking into the NGS. That's also important. A very quick, Shitish, Topo2. We have sacituzumab. We speak a lot in the medical oncology forums. It's exciting drug in the later lines. Do you think that Topo2 marker is something that you would look into when you are considering, let's say, sacituzumab, which will come to in a minute? Do you think that this is a marker you would look into and then decide sacituzumab?
Sir, Dr. Samir has joined.
Okay. Dr. Shitish, please take this and then I'll ask Samir this.
Yeah.
Shitish, yeah. Shitish, you're there?
Yeah.
So Topo2,
So-
any opinions on Topo2?
So basically, if it is available, definitely, I would like to know more information about it, because we know that it acts on the sacituzumab acts on that.
Okay, so I'll come to that, because see, this is important for us to know that the markers are there, which markers does make a it does make a difference. If it is high or low is something that we will stress upon. What is the data on this? And let us look into what we have spoken, and this is the options for this patient. Samir, triple negative breast cancer is there for you with a liver and lung metastasis. The biochemistry is well maintained. Very quickly, your treatment of choice.
So metastatic TNBC front line, first line.
Yeah, first line, untreated.
Untreated.
Yeah.
So basically, sir, taxane platinum will be the chemotherapy regimen of choice for me.
So taxane plus platinum is your chemotherapy of choice. You believe in the concept of single agent, or you believe in the concept of adding a platinum to a taxane?
Sir, in TNBC, I try to add platinum.
Okay, you try to add platinum. So is any trial there to show a superiority of a platinum combination versus a single agent?
No, only response rate will be better.
Okay.
So for that only.
Okay, so if you look at the platinum part of it, I was just going through which platinum. Any preferences, Vikas? Cisplatin versus carboplatin. Any preferences in this part?
So I'm not using upfront, sir. Like I'm using single agent chemotherapy. When it comes to the platinum, like both are okay, sir. Like I do
Okay.
not find any difference with either carbo or cisplatin, sir.
Okay, so both of the platinums are okay. And Mansi, if you have a BRCA positive, would you go and try the carboplatin or cisplatin single agent? Are you adventurous enough in your patients, well preserved, frontline? Would you do that in a practice?
So to be very honest, I've for most of the metastatic patients, they've had a high burden of disease, so I've ended up using doublets. But
Okay.
if I were to use single, I mean, if low volume of disease and the patient is not that symptomatic, then I would definitely consider single agent platinum.
Okay, okay, okay. Dr. Ankit, you are there? No. Okay. So this is one data which is there in a phase 2 data, which shows that if it's a BRCA positive, platinums do well in the mutated than wild type. If you use a platinum, it is better to use in first line than second line. It is consistent for cisplatin and carbo. And cisplatin was equal to carboplatin if you look at it. But if you look at the absolute numbers, probably cisplatin was superior to carboplatin. There was also a marker because it is a moderation of markers. There was some marker on P63 by P73 ratio, which has to be more than 2 in the initial trials. If it is more than 2, then the response to platinum is superior, but it did not stand that test in this trial. So if you look at the TNT, same thing, carbo, dosi, all of us know this and spoken well enough. It is similar, but once it comes to the mutation, germline or tumor, then somatic, the platinum single agent scores superior to the docetaxel. All of us know that, but the most important thing is if it is methylated or if it is a BRCA1 mRNA low or non-methylated, it does not make a difference. Either docetaxel, carboplatin means carboplatin or single agent should not be used in this type. The only type which you should use it is in a mutated BRCA, where Mansi told she would probably prefer it in a low volume because of the responses. I think that's what Samir told. So now let's come down to the sacituzumab. Anyone here has experience of this drug? Shitish, you first, yes, no?
Personally, no, but in
No?
our group, there are few oncologists has already used
You
and
have
they have
already used.
seen a good response.
Okay. So Mansi, if this drug is there and you have a BRCA mutated, you have failed platinum, let's say frontline, would you go for a PARP inhibitor or would you go for a sacituzumab?
I'm sorry. So in BRCA mutated patient, you're asking that?
Yeah.
So I think I would go with the PARP inhibitor first.
So you will initially go up with a PARP inhibitor and then probably go for sacituzumab in the later line. That's what you want to tell me.
Correct.
Okay. Yeah. Samir, any difference if you have a PARP if you have a BRCA mutated?
Yeah, definitely. Samir, for with olaparib, we have a very good data now. So I think PARP inhibitor first, BRCA mutated, and then only maybe the sacituzumab govitecan once it's become available for us.
Okay. Vikas, any difference in this sequencing of therapy?
Sir, as you specifically asked, that patient has progressed on platinum.
Yeah.
So if patient has
No,
progressed on
no. The patient, let's say, has not progressed. I understand that makes the PARP ineligible for you.
yes, sir. Then if patient has not received platinum, then PARP is
The
a good
patient
choice.
has received platinum. There has been a drug holiday, has not progressed on platinum.
Okay, then I think olaparib is a good option, sir. Oral tablet and better safety, sir.
Okay,
Data
I will come to the sacituzumab very quickly on the what we spoke about in the PARPs. The front thing is if you look at all the PARP inhibitor, the trials of let's say Embreca or let's say the Olympiad, it is actually in the earlier lines, it has been used lesser than 2 or less cycles of therapy. Some trials have used it in 3 or lesser. Basically, if you look at the use of PARP before platinum and after platinum in every trial, in every subgroup, you most likely will find that prior platinum use inhibits or shunts the efficacy of oncological outcomes with PARP. So my point of saying is, if you look at the data and if you have the option of using it, use PARP earlier than later, and the responses and the efficacy probably will be superior, but you would not be doing harm if you're using it post one-line failure of platinum. Now, looking at the sacituzumab, the data is there for all of you to see. I am not going to repeat the data, but this is something which I want to highlight and ask the opinion of the house, especially when deruxtecan gets available. So now my context is you have a PARP inhibitor after let's 3 years, you have a sacituzumab, you have a deruxtecan. So Kshitij, if you all the three available and the patient is a BRCA mutated, how would you sequence your therapies here? Kshitij.
BRCA mutated and that
Everything is
HR
available.
HER2+1.
HER2 is 1 and FISH is negative.
Okay. And it is a brain mets or no brain mets or either
No brain
something
mets.
like a
No brain
and
mets.
burden of disease is limited.
No, we have liver and lung metastasis without compromising any of the lab parameters. And PS is still 1.
Okay. So still because of the familiarity of a drug, I may be wrong, but my first preference will be olaparib earlier and then followed by sacituzumab and trastuzumab deruxtecan.
So yours will be
there is
olaparib
not
followed by sacituzumab, then deruxtecan. That's how you will sequence it.
or otherwise, yeah, currently.
That's fine. There's no right or wrong answer in this. I just wanted to know the opinion. Mansi, you're sequencing.
So I think for a BRCA mutated, I would probably go with a PARP inhibitor first because, as you mentioned, they seem to work better upfront. Followed by a chemotherapy regimen, mostly taxane and platinum, which would then be followed by sacituzumab govitecan and then by trastuzumab deruxtecan.
Okay,
I think trastuzumab
you are putting the deruxtecan little down the path.
I think because it probably does have a pretty good activity in refractory patients.
Okay.
So I think probably use it later on.
Samir, everyone wants to use a platinum, and there is at least 2 trials of veliparib with a platinum and one with a platinum and a taxane. And that's the Brocade and SWOG trial. And if you look at the trial versus a single agent veliparib, the combination has shown superiority in terms of PFS. So would it not be a very attractive option to add this if you have the drugs available to you, you want to use a PARP frontline? If the PFS data is superior in 2 trials, if you add a platinum to a PARP, would you do that or would you just go for single agent PARP inhibitors?
Sir, but the data with chemotherapy and olaparib combination is not there, what I remember.
Veliparib. I told veliparib.
It's for veliparib. So veliparib is not available for us.
If it is.
I think its job is easy for us. But I think definitely it will add to the toxicity. So we have to see that part also. Because even single agent PARP inhibitor is not easy to handle sometimes.
Okay. So there are 2 things which I wanted to leave the house with the thought process of this, that there are 2 data and both data is veliparib. And both the data, one with taxane and carbo, one with veliparib with CDDP, and the 2 trials, both of them showing a PFS benefit, because none of the PARP inhibitor trials have shown OS benefit till now in the metastatic setting. So that could be a combination if it is really coming up, and the further trials across the PARP inhibitors show this efficacy to be there with the combination chemo. Number 2, I would like to have one option because I feel my personal thought is sacituzumab could be my 3rd line agent. I would go for deruxtecan at the 2nd line, because if you look at the sacituzumab and it is for beyond more than at least 2 lines of therapy, and deruxtecan is the destiny was more than 1 or more. So there is nothing wrong or right which both my colleagues spoke about. But look at this forest plot, and if you look at it, numbers are quite impressive, and both the way, even if more than 3 lines, I do find sacituzumab govitecan an effective agent. So this is something that really, I think, I'm not sure, but that is one thought process which I had, that I probably can use it. And even in the prior use of PD-L1 or PD inhibitors, also you have this drug active. So these are 2 things I wanted to speak about sacituzumab. Samir, before you came in, I was speaking about the TOPO2. Do you think that a TOPO2 is a good marker for using sacituzumab?
So what I remember, sir, the benefit was irrespective of that.
Okay.
So we can use it in all patients. There is no need of biomarker.
Okay, there is the trial of ASCENT which has come up. This is the last year publication in Annals. And if you look at it, the topo score of H score of more than 200 is something they looked at for high. 100 to 200 is for medium, and less than 100 is for low, is IHC scoring. And what they found is if you look at the responses, it was nearly similar, but little more impressive for the higher or the medium topo scores. But if you look at the trial concluded that for topo medium and topo high, there was the superiority of sacituzumab. For the low topo, they did not have enough data and numbers to make a draw a conclusion. So what Samir says is probably the way I would also look at it. But if you look at the purest way, the low topo, they are not sure in this ascent analysis. They did not have enough numbers and events to conclude on the low topo. Okay, this is the destiny. I will just ask one thing, Mansi and then Vikas. The destiny, if you look at it, had only 1% patients in this trial who were triple negative. And the numbers, if you look at it, was around 50 patient number. Is this number of patients data enough for you to go ahead and assume that deruxtecan is a good drug for the HER2 new low triple negative breast cancers?
I'm sorry, I didn't. So triple negative, there was 1%, but
see, if you look
low,
at the HER2 new low data which you're speaking of, 99% of these patients were actually HER2 new hormone positive. And the data set of around 400, around 500 patients, 99% were hormone positive. Only 1 to 2% were hormone negative, means triple negative here.
Correct.
And this data, if you look at the absolute numbers, was around 50 or 55. So when we speak of the level of evidence and the quantum of the numbers, does this data impress you to go to this drug in a triple negative, was my question.
So yeah, I won't use it in a triple negative per se. Like, so the patients who are HER2 0.
No, I'm talking of HER2 new 1 or 2 FISH negative.
So in this trial, though, there were patients who were HER2 +1 +2, right?
Yeah. And who are FISH negative.
Yeah. No, so I think based on this data, I'm definitely convinced in using it in patients who are HER2 1+ or 2+, but FISH negative.
Okay. So basically you're telling the numbers do not much affect you, the 50, 55 numbers in a trial, you can and you feel this number is good enough.
Yes.
Okay. Vikas, any difference of opinion, or would you like to see a larger trial on this patient subgroup to convince you?
Yes, sir. So at least for this subgroup, I think larger trial is needed. Sir, can you go to the previous slide? One more interesting observation that I picked up.
Tell me.
That if you see the pattern of metastasis, like if we see ERPR positive, HER2 negative, most of the time they are the bone metastasis. But here we can see that the liver is the most common site of metastasis. So I think the HER2 low is a separate entity rather than the man-made entity.
I'll tell you something, because what I read of it is they have not included the bone part. They have looked into the visceral disease. That this chart only tells you the visceral disease. You would still find bone to be the most common. I think that's what I read of it, because.
Okay, sir. I will again recheck.
Yeah. So numbers you would like to just wait, but only one thing. I think Mansi is right in a way that if you also add this and look at the hazards now ratio of the patient, all patient and the hormone positive patient, actually they are similar. So that is why they are concluding that probably the 50 or 60 patient data does not even change the hazard towards the negative, towards the opposite side. That's why this looks convincing. But I agree that I would like to look at larger patient load. It gives me more confidence. PARP inhibitors I've spoken about. Samir, before you came, we were speaking of the PALB2. Do you look at PALB2?
So, sir, from treatment point of view, not, but maybe from the hereditary point of view, because it is one of the gene which has a very high risk of developing breast cancer.
Okay, I'll show you this data very quickly before I have one more data set and then we conclude. Look at this data. This was published in the San Antonio 2021. This was looking at patients who were negative for BRCA1 and BRCA2. Dr. Prashant can speak little more on this. This patient who were BRCA germline negative. The cohort 1 was those who were somatic and germline negative, and 87% had a ATM check to PALB2 or Cohort 2 had somatic positive BRCA, but germline was still negative. So this is the difference between cohort 1 and cohort 2. Cohort 2 had somatic BRCA, but cohort 1 had somatic BRCA also negative with also germline. And look at the responses. If you look at the responses with the drug olaparib 300 milligrams, the numbers are not very huge. But if you look at the responses, it looks a pretty steady 30-35% of his partial response is stable of around 35 to 40, means a response or a benefit of around 70 odd %. And if you look at the things, although it's a proof of principle study, they looked at that the PALB2 mutations, the response rates were around 82%. And the second best was the somatic BRCA mutations of around 50%. The other mutations did not benefit much. And if you type PALB2 and triple negative response to PARP inhibitors, you will find multiple case studies. Dr. Prashant, is it that phenotypically PALB2 looks very similar to the BRCA mutation positive patients?
Yes, doctor. In terms of the pathways where the PALB2 play a very important role, it is in both the genders, because we also have seen the PALB2 in the male cases like breast cancer, which are in the both the metastatic ones. So PALB2 has the similar pathway with regard to this, both the BRCA1 and the PALB2, doctor. So that's the reason it has that higher risk, and also probably I'm seeing now, happy to see that there is a greater response, overall response to the.
So the ATM and CHEK2, the data is not so convincing. So in the lab, do you look into, and are you just excited, or it's more of a hereditary risk that you are more excited for?
We do look at these if there is a like from the perspective of the panels, these all come under the different panel like ATM and CHEK2 and the somatic BRCA and all. But if I'm looking at the,
but if I run an NGS, but all this come in one go.
Yes, correct. Yeah. But what I meant was like PARP inhibitor, doctor, the HRD assay, if it is there, then I'm only considering the somatic BRCA1-2 and related whatever the LOH, LST and TAI. We will not include the PALB2, ATM and CHEK2 in those cases. But in the cases like you rightly mentioned, there has been a metastasis in other cases, and also they have done some first line kind of a treatment, and recurrence cases, they go for then the detailed complete somatic one. So there we have a good data about response to this ATM, and in the Indian perspective, there has been some responses to CHEK2 inhibitors also now. Yeah, okay. CHEK2 genes. Yes, sir.
I'm not aware of that part of it. So this is what Mansi spoke about, the AKT inhibitors. The phase 2 data was very, very impressive. That's why they run the phase 3 data. It is more of the PTEN, PI3K and the AKT pathway, which we're looking at. And we have a drug called ipatasertib. And if you look at this trial based on the phase 2 data was run. And this was along with the weekly paclitaxel of weekly, the 1-8-15 as we do, and the study drug versus a placebo 2:1 randomization. It was a negative data. So Mansi, this is the data for a phase 3. The data for phase 2 was impressive. That's why this was run. So unluckily, this data is not exciting us for the PFS. Is just curves are just matching each other. Last, before I close,
sir, just a minute. Please. Sir, this is overall population, but I think in AKT mutant population there was the benefit.
I know, but is it still approved for the alt mutations?
Sir, Miss what I remember in both phase 2 and phase 3, in AKT mutant population there
was a positive data for phase 2.
But in AKT mutant population there was a more benefit. I think
there was a more benefit that I concede. But is it approved FDA? I'm not sure of. Mansi, is it approved by FDA?
I actually have to check. I'm not sure.
So I think I have to check. But my understanding is that this phase 3 data was little a setback.
Even sir, capivasertib was similar. In AKT mutant population, there was a benefit.
Okay, so I'll just check on this. So last word, Samir, when you use even checkpoint atezo,
right?
Do you use it? Number one, if you use it, do you use a nab-pacli or you use the paclitaxel?
So, sir, I think data for pembro is better in triple negative rather than atezo. And whenever I try to use immuno, I always try to use nab-pacli rather than only plain plaque letter to
So
avoid
the first
steroids.
thing is you do not use atezo because of what has happened, and second, you are more, it will be more into the pembro rather than atezo. That's what you're
Yeah.
looking. And if you use it, you'll go more towards nap-pacli rather than pacli. That's the
Yeah.
three conclusion.
Yeah, right,
Dr.
right.
Vikas, any difference, or you concur with Samir?
Yeah, I 100% concur with Samir.
Okay, Shitish, anything different?
No, same.
No. Okay. So, if and anyone has any impressive data on monotherapy of immune checkpoints? No. Okay. It is-
Monotherapy, no, sir.
Okay. Even the data is not there. If you use it with chemotherapy. Last, the androgen receptors. Do we check for it, Shitish? In your practice, do you routinely check for androgen receptors?
Routinely, no.
For triple
but
negative.
in NGS. Routinely, we are not, but
Okay.
in NGS, and if it is progressing, sometimes.
Okay. Mansi, androgen receptors by IHC? Vikas?
So,
Yeah,
sorry.
No, sir,
Mansi,
I'm
please.
not
Mansi,
checking.
yeah.
So I know there is a lot of like I think a lot of people want to use the androgen receptor inhibitors. I've used it in like a handful of patients who are not really good for any other treatment and
And
have really
which
had
drug have you used it?
enzalutamide.
Enzalutamide. Okay.
But I've not
160
seen any
milligrams?
responses. Yeah, but I've not seen any responses.
So
I'm
did
not
you
like
do
very.
did you do the
I
androgen
did
receptor?
the androgen receptor. I
And
did
it
the
was
androgen
positive,
receptor.
and any score you had any score for that?
I don't remember right
You
now,
don't
but
remember.
it was good positive.
Because
Like in the sense yeah.
yeah, please, Mansi, complete.
No, so I'm not very enthusiastic about this whole pathway, to be very honest.
Because
I'm not checking, sir.
you do not check. Samir.
So I did it in few patients. None of the patient came positive. But I think the data is for both enzalutamide and even bicalutamide. But the PFS benefit is just, I think, 1 or 2 months. There is no great such response also. So I think it is in end stage when there is no option available and patient just want oral therapy. Maybe tried if the AR is positive, but not as such a great drug in this situation, I think.
Okay. If you look at it, you should look at the androgen receptors, the nucleus more than 10 equal to 10%, more than 0 is positive. But if you look at more than 10%, the data is little stronger. There are two drugs, antigen which can be used, SP107 and AR441. That is the point number 2. We have to look into the antigen also. And if you look at it, if it's more than 10 versus less than 10, there is a difference. So just a positive report. Please check that if it is more than 10 only, you might get a benefit. And it is specially acceptable that you do not use it in front line. You use it in later lines when you've exhausted 2 or 3 lines. And all of you are right that responses are not very huge. 10% is the cutoff. And number 2, if you look at the efficacy of the benefit at 24 weeks, it is around 20 to 30%. That's what it is. The responses are single digit at the most, less than 15 or 20%. The PFS is around 2.5 to 3 months. So that is it. But the overall survival, even in spite trying in third line, these patients have a median overall survival around 10 to 12 months. So that is something I think we can and we should look into after a failed 2 to 3 lines of therapy. So this is where I will stop with thing that I will look into the AKT inhibitor approvals. I'm not pretty sure of the approvals. I may be wrong in this, but Samir, I think one of us should post it after in next 5 minutes whether it was approved as per this data. But yes, the subgroup analysis did show a benefit, but whether the approval came or not, I'm not sure. I'm sorry. I accept.
I don't think it's approved. I actually looked. It's not approved.
Yeah. So that's what my thinking was. Is there any other target or marker which we have left out, Dr. Prashant?
No, for TNBC, all these details
Yeah.
are covered.
So anything in the panel, 4 of you, would you add something before we hand it over and I do my take home list?
Theoretically, they have mentioned some RTK pathway inhibitors and
Yeah.
any experience of something like that.
For me, no. If you look at even the androgen receptors, the most of the new trials are looking at androgen receptor blockers plus the PIK3 inhibitors. So because there are later lines, the resistance pathway comes in. That's why they're adding the PIK3 to the androgen receptors. So a lot of new data is coming off, but I don't think that was anything which I thought was there worth presenting, and do not have a level of evidence where we can change the practice. So yeah, Samir.
Sir, so if you see the means like for targeted therapies, whatever we have, so P10, loss of P10 is one of the common thing which we seen in TNBC rather than in ERPR positive. PIK3CA mutation is also seen in around 30 to 40% of the cases. So for PIK3, we try to use sometimes like mTOR inhibitor like everolimus, something like that. But for loss of P10, if the means like the report, NGS report shows you there is a loss of P10 gene. So how do you target that? Any way you target it, or you just try to give chemotherapy?
I just look into the report and then I do my old chemotherapy.
So see, loss of P10 again, it is a marker of activation of PI3 AKT mTOR pathway.
Yeah.
So in that case, can we use like everolimus?
There are some data that I was going through the articles, and there are some data, but I don't think there's nothing as a level 1 evidence or even a high level 2 which you would recommend on a trial, except for a trial setting. Mansi, agree to that part?
PARP inhibitor at present as approved targeted therapy. Otherwise, there is no as such great target therapy at present for maybe like sacituzumab govitecan and the TDX coming in pipeline. But I think at present only we have PARP inhibitors.
We have PARP inhibitors. The sacituzumab is something. The AKT inhibitors are not going to go away. We are going to come up with better AKT. That's one big pathway, I feel. The PIK3 target is something that everyone wants to use it.
There was sorry to interrupt. There was a clinical trial with us in the past where they have used PIK3 inhibitors when there is a P10 and PIK3 mutation was positive in TNBC. I don't know the result of that trial, but
so most of the trials are targeting these two pathways. That's what I was concluding with, that this is because if you are failing first line, you would have a resistance in these pathways, and this pathway gets activated. That's why the later lines they are adding these drugs. That's what I wanted to finish off with. The take home: neoadjuvant immune checkpoint are getting more acceptable. Platinum are higher responses. PARP inhibitors modest benefit, but you use it little up the line rather than down the line. Sacituzumab is the happening thing. And I think this is one drug which has shown activity even in third line, very impressive results. TDX is the new kid, and there are still a lot of things for us to learn. For me, 60 patient data is something I would like to have a larger number, but I think the data looks good enough, and most of the experts agree, at least in the HER2/neu 1 and 2 FISH negative. What would be the current sequence? We did this, and most of our panelists spoke of using a PARP if the target is there. Then go to deruxtecan, and then go to then use sacituzumab, and then go to deruxtecan. I wanted to use the sacituzumab little earlier, and I am very much interested in knowing the further trials on the PARP inhibitors and the chemotherapy combination, and that will probably then push the platinums and PARP together. So that's my take on this, and thank you, organizers. I hope we added some value to this academic meet. Thank you.
Thank you.
And thank you, panelists.
Thank you, DP
Thank
Sahu,
you so
sir.
much, Dr. Sahu.
Yeah.
Okay, so
thank you.
So we'll move to the our last panel discussion. So I would like to invite Dr. DG Vijay sir, and he needs no introduction. And sir, we kept our promise. We are only 2 minutes left. Late. So Dr. DG Vijay sir is a senior consultant surgical oncologist at SCG Hospital, Ahmedabad, and he would be discussing local regional treatments in metastatic breast cancer. And I would like to invite the esteemed panelist, Dr. Manthan Merja. He's a surgical oncologist, Talent Cancer Hospital, Ahmedabad. Dr. Abhishek Jain is a senior consultant oncosurgeon from Selby Hospital, Ahmedabad. Dr. Preetam Jain is a consultant medical oncologist from Bombay Hospital, Mumbai. Dr. Vikas Asati, Indore. He's a oncologist. And Dr. Gautam Makadia from Rajkot. And Dr. Kinjal Jani is the senior radiation oncologist. So over to Sir Dr. DG Vijay sir.
Vijay sir, before you start, Sahu here, मैं बस
Yeah, yeah.
टाइम देख रहा था, 25 हुआ, अलार्म बजा, मैंने बंद किया। मैं बोला विजय सर मेरे गोली मार देंगे।
साहू सर, I want to make a comment. सर
Yeah.
आप अगर लेक्चर ले रहे हो ना, तो विजय सर 5 मिनट वेट कर सकते हैं।
अरे भगवान,
आपके लिए 5 मिनट वेट कर सकते हैं।
पूरी जिंदगी कुर्बान है यार।
अरे यार, thank you sir. Please carry on sir, please
It's
carry on.
not meant at you at all. You have been, you lead such stimulating discussions on breast cancer and other topics. It's always a pleasure that you agree to participate in our panel discussion.
Thank you sir. Please carry on sir. Please carry on. Thank you sir.
Thank you so much. First of all, I would like to thank Team OncoWin for having given me this opportunity. Share the screen. And the Global Oncology Forum for having put together this breast cancer update. Pretty stimulating till now. I would also want to thank Hitesh Khatwani, Rishabh Kothari, Gaurang Modi, and Palak Bhatt. I welcome all my panelists, and I will now just share my screen in a minute or so. Geetika, do you have all the panelists? Yeah. Can we do full screen?
Hello.
Yeah. Full screen. Can you
Sir,
see
am
my
I audible?
Yeah.
Good evening.
So the topic.
Sir, am I audible?
Yeah.
Okay. Okay.
So the topic is local regional treatment in metastatic breast cancer. I am Dr. D.G. Vijay. I am the the president-elect of ABSI and surgical oncologist at HCG Cancer Center. At the very outset, I would like to invite you all for EPSICON 2023, of which Dr. Kinjal Jani and Dr. Mansi Shah are the organizing secretaries. That is to be held on 28th, 29th, and 30th of July. Primarily, what is the role of the surgeon in doing loco-regional treatment in metastatic breast cancer? So, stage 1, 2, 3, obviously, long-term disease survivorship cure theory is possible, but stage 4 cure may or may not be possible. Next. So basically, metastatic disease is divided into two categories. One where we have very extensive disseminated distant disease versus there is a small subset of patients who have low volume metastatic disease. So the topic that we are discussing, obviously surgeons are very much evidence-based medicine we practice, and we would not do surgery when there is extremely disseminated distant disease. But whether there is a role of the surgeon, because we are being constantly pushed into the corner by medical oncologists like my friend Sahu and Modi and the others, whether there is a role of the surgeon in low volume distant disease. Next. Some of the slides that I present here are borrowed from my friend Dr. Neeta Nair, who recently left Tata Memorial Hospital. So there is oligometastatic disease is a specific entity representing a specific condition between locally confined, like stage 1, 2, 3 breast cancer and non-curable metastatic disease. So between early disease to locally advanced disease, there is a subset catch in between called oligometastatic, and then it progresses to the full-blown metastatic disease. You can see this slide has been, of course, borrowed from Shahina Dawood. Small primary tumor, no nodes, 90% chances of cure, locally advanced,
50% of chances of cure, and whether there is a small window of opportunity that the treatment of gives us, where we can do some form of surgery, and loco-regional doing the breast surgery, doing the nodal dissection helps in the overall survival is the question. Of course, with widespread metastatic diseases spread to the brain, liver, multiple nodes, we would definitely not do surgery. So next slide. I would want to ask the panel, Kinjal, Abhishek, Mirja, Manthan, what are your thoughts on what would you define as oligometastatic disease? Kinjal.
Yeah, so for us, again, this is a term where it's a variable thing. Some people prefer 3 sites, some people prefer 4 sites, some people 5 sites. But basically, when you talk about oligometastatic for breast, it is about a very low volume metastatic disease along with the primary disease, where the site of involvement is less than 4 or 5.
Correct.
You would tend to be more aggressive in treating those patients because you have a lot of systemic treatment for these patients, and you would tend to try to cure these patients and go for a radical treatment rather than going for only palliative treatment. So these are the oligometastatic cases.
Absolutely. The intent of treatment is cure rather than just pure palliation. Manthan, any other thoughts? Abhishek or Vikas? You want to add anything to the definition of oligometastatic breast cancer?
Yeah, I agree with Dr. Kinjal Jani, sir. As far as the breast cancer is related, and when the surgeons are involved, typically oligometastatic disease is mostly considered as the bone-only metastasis, very low burden, 2 to 3 at the max site, because those are the cases where we can give a chance of curative intent treatment.
Absolutely. So de novo metastatic breast cancer accounts for about 6 to 10% of newly diagnosed breast cancer cases. What has happened is that modern imaging techniques like PET CT scan, for example, and the MRI have sort of opened up all new sites of metastatic disease, and some of these tests have higher sensitivity and higher specificity than conventional imaging. So wherever we see stage 2, stage 3 breast cancer and we do PET CT scan, there is a likelihood that we might uncover metastatic disease, either, as you said, in bone or liver or lung, or sometimes rarely in the brain as well. So there is an increasing yield for occult distant metastasis in patients with an initial diagnosis of clinical stage 2, especially stage 3. So many of these cases we think will go for neoadjuvant chemo, but they turn out to be metastatic breast cancer. And we have to be very clear at the very outset whether we are treating these patients with a curative, like Kinjal said, curative intent or a palliative intent. And what is the likelihood of survival in terms of months or years for these patients? Next, Geetika. Yeah. So Abhishek, at Shelby Hospitals, do you treat oligometastatic breast cancer, or a new terminology called oligorecurrence? No, you have done surgery and 3 years down the line, 5 years, 10 years down the line, the patient develops hormone receptor positive patient develops an isolated bone metastasis. Radical curative intent, or once it's gone to the bone, gone to the liver, gone to the lung, isolated, couple of 3, 5, what would your take be? I know you are very aggressive. You are muted.
Yes, sir. So this is one such category where you rightly mentioned there is a window of opportunity. The surgeons see a window of opportunity, and for such category of patients in the whole line of treatment. I mean, oligometastatic can be a metastatic disease to a single site or a single organ. It could be a bone only metastasis. It could be a liver only metastasis. So there is definitely intent of cure for such patients, and especially when the patients are luminal breast cancers, luminal A or luminal B, less than 55 years, single bone metastasis. So this is one such category which has consistently shown positive results in all the trials which have been conducted, sir.
Oh, you've
So
been
this is
trying-
one such category which I would aggressively treat.
Trial based on which you have decided to operate women who are. Anyway, Geetika, can we have the next slide? So, next. So, like Kinjal Jani said, like Abhishek said, Banthan said, so depending upon the number of metastasis, time of presentation, organ involved, number of organs involved, primary sites, the biology of the disease. I think Abhishek very correctly pointed out that in hormone receptor positive, Kinjal also referred to the same topic, that in a selected subset of patients, we might consider loco-regional treatment in some of these patients and access to treatment. In a HER2 positive patients, if the patient has access to both trastuzumab and pertuzumab, certainly even with metastatic disease, the outcomes are going to be far different than from a patient who doesn't have access to treatment. So these are some of the top points on which we are going to make the decision whether to consider loco-regional treatment or not. Dr. Preetham, any other thing that you would want to add at any point of time, regarding whether you will, I believe that you are a medical oncologist, and whether you will refer to your surgeon to consider loco-regional treatment in a lady who has metastatic breast cancer.
You're muted. You're muted.
Yeah, hi. Now, I'm audible?
Yeah.
Yes.
Yeah. So I agree with all the panelists. Now, I do come across such situations where there are metastasis to certain different parts of the body. Like sometimes I get solitary 1, 2, 3, 4, 5. I would definitely, this is one situation I make sure that the surgeons and radiation oncologists are sitting along with me with the final conclusion, so that patient doesn't get confused, because this is one area where difference of opinions are bound to happen. So if there are oligometastasis, especially to the bone with a luminal A type, I would certainly want my surgeon to go with a radical curative intent. Now, the decision whether to operate first or go ahead with the neoadjuvant is a matter of discretion amongst the experts. But definitely the intent has to be decided upfront.
That opens up a whole Pandora's box. Abhishek Jain, what would be your choice? Suppose the patient has oligometastatic disease. Will you consider systemic treatment first, followed by loco-regional treatment, or vice versa?
Yes, sir. Sir, that would again depend. I would look at the staging of the primary tumor. If the patient has presented with a fungating mass upfront, with a metastatic disease, with a oligometastasis, then I would definitely like to address the primary immediately.
Okay.
And then suppose if it's a small T1, T2 tumor with N1, and the tumor is not causing significant local discomfort to the patient, then definitely I would like to start with a systemic treatment first. Then later on, I would definitely like to incorporate surgical management as a part of the whole management of the patient.
But I'm sure systemic treatment will certainly make the fungating tumors also smaller, making the resection much easier.
Yes, sir. Yes, sir. Definitely. My preference would be to start a systemic, but some patients, they do come with a very foul-smelling mass, but that is very rarely seen. That was a scenario more common in GCRI, but right, sir.
Can we have the next slide?
So, right, sir. So systemic first, followed by surgery. Because, sir, if we can offer a small surgery like a lumpectomy, LND, why not to?
So, defining oligometastatic disease has become a big challenge. So, the original definition was an intermediate state between local and systemic disease, where radical local treatment of the primary cancer and all metastatic lesions might have a curative potential. A beautiful definition. Disease burden, small burden of low volume disease, 5 or less, 3 or less, limited number of sites or regions, single or limited number of organs, limited number of metastasis and sites, limited number of distant metastatic, typically 5, which is the maximum that we allow, that contain the primary. So all 5 lesions are in the lung or in the liver. So more indolent disease, by which we mean ERPR positive, tumors featuring limited metastatic capacity and specified for certain organs, pulmonary dissemination, nodal recurrence. Next. So up to 5 and up to 3 have been various definitions. I think this is what Kinjal was referring. It could be either synchronous, a de novo metastatic breast cancer, or the oligomats could appear subsequent to treatment of the stage 2, stage 3 primary breast cancer. Next. I thought this was a beautiful slide that I borrowed from Dr. SVS Dev. So it could be synchronous, oligorecurrent breast cancer. We have oligometastatic breast cancer definition, up to 5 lesions, not necessarily in the same site organ, all potentially amenable to ablative treatment. So you could have radio frequency, you could have radiation, radio frequency ablation, surgery, anything, and it's a more or less an intermediate stage between locally advanced breast cancer and widespread metastatic disease. Next. The reason why we came up with this concept of addressing the primary is this, that there is parental metastasis to metastasis dissemination. Primary tumor continues to be a parental source of seeding. Like the tumors, whenever we do systemic treatment as well, so there are, sometimes we see patients with CA breast with bone mats, and subsequently it goes to the brain. So either it has gone from the breast, or it has gone from the brain, from the bone or the liver. So, whether we can address the loco-regional treatment and the metastatic site. So it could be metastasis to metastasis dissemination, as you can see in these, from the bone, from the liver, or from the lung, or it could be from the primary. So, these are all hypotheses that we are working on. There is absolutely no clear guideline that we can say, and none of the guidelines really clearly, and in fact, some of the trials are not even in favor, but there is probably some data to show that addressing the primary, addressing the metastatic site in some cases selected, might lead to some better overall survival. Next. Any of the, have I left out? Vikas has been added. Gautam Makadia, you want to define oligometastatic breast cancer in Rajkot? Does it any different from what we have discussed till now? People in Saurashtra are a different breed, so you might be doing something different.
No, sir. Almost all the things has been said correctly. I just want to add one thing more. When the patient's systemic disease is very well controlled, most of the time, patient's disease biology is good, and patient's loco-regional treatment is not that morbid to the patient.
Correct.
The patient is in a very good physical shape. Then I would like to add these things
apart
from
correct,
like loco-regional treatment, right, sir?
So good response to systemic treatment, good performance status. You might consider loco-regional treatment in some of these cases. Next. Next. So to conclude, number of lesions, site of metastasis, biology of tumor, response to treatment. I think we are going over the same thing over and over again. There is an ESMO guideline for Kinjal Jani and Pooja Nandwani, who is not here. There is an ASTRO consensus state which clearly states that in a small subset of patients, there might be a role for considering loco-regional treatment. Next. But what is the current data for treating some of these patients? Let us come to the first case. It's a triple negative breast cancer, IDC3, very aggressive disease, T4N2M1. She had multiple liver metastasis, and the largest one was on the left lobe, 2 centimeter. So let me come to the medical oncologist, Dr. Preetam Jain. So she has liver metastasis. So what will be your intent of treatment, palliative or curative?
TNBC with
5
multiple
is the
liver.
cutoff. This lady has 6.
Yeah, this lady has a 6. So I think it's, I would go with a palliative intent and upfront chemotherapy in this case. This is M1 straight away. Possibilities are there that post chemotherapy, these lesions goes under remissions, but still I would like to treat as M1 and palliative intent.
Okay, what will be your choice of drugs? Anything that you would want to add extra just because she has MBC, TNBC?
So this is TNBC. Generally, we prefer taxanes and platines upfront. I mean, there is no difference whether you give a single agent or a combination of treatment. At the end, the overall survival does not make a huge difference. So after assessing the patient's fitness, performance, and tolerance, initially, I might go with a dual doublet chemotherapies.
Gautam, you agree to that? Single agent, double agent. So what will be your idea? Palliative, curative? You know, you are looking at a young lady,
Yes,
45-year-old.
Sir, I would discuss the things with patient. I will see the patient's performance status, comorbidities, and I would like to push them for somewhat in between curative and palliative for long-term disease-free survival. And I would initially opt for aggressive approach if she is responding very well to our treatment. And our as discussed earlier, I would on day one I would discuss with the surgeons and radiation oncologist as well as interventional radiologist whether these lesions are amenable to local treatment in future or not at any point of time. If any of them give me a positive sign, then I would like to give more of curative approach because considering the age. But I would definitely explain the relatives that it is a metastatic tumor. So it might not happen that what we are doing is not, maybe it is not going to give a better survival, but let's take a fair chance to her.
So you give 6, maybe 8 cycles of neoadjuvant.
Yes. If responding very well, her performance status is
complete resolution of liver metastasis. So like Dr. Preetam said, in triple negative breast cancer, you expect good results with chemotherapy. All the 6 liver lesions have gone away. So my question to the panelist is, will you change the intent? Do you plan to remove the left lobe of the liver? Consider doing a mastectomy, T4 lesion. So mastectomy followed by liver resection, left lobe. Just remove the left lobe. Manthan, yes, no?
No, sir. Not in our practice.
Preetam, you would refer to your surgeon.
Yes.
And tell him to do a mastectomy. The lesions have gone away. Even if there is PAT CR in the breast, in the node, in the liver, and then you have some idea of giving something in the follow-up. So you think that an aggressive approach like that would be helpful in some young breast cancer patients?
Yes, sir. Yes, sir.
Yes. Kinjal, you have put up your hand. Go ahead.
I want to.
Sir, I would definitely go ahead with surgery in such patients. Since there is a complete metabolic resolution, and sir, there is I understand that there is a dearth of randomized control trials for such lesions, such patients. But still, there are many studies, and all the studies have shown that there is a reduced risk of death because of breast cancer.
Okay. Kinjal, you want to say something?
So, I wanted to make a comment. I would agree with Dr. Preetam that this
is such a good response surgery at all.
Thank God, finally somebody.
Yeah, so I agree with Dr. Preetam that this was a palliative case to begin with, and my intent would not change. Even if there is a CR in liver metastasis, you cannot do SBRT, you cannot do radiofrequency ablation. RFA and SBRT cannot be done. So if you're thinking about a resection of the liver, it may be possible, but a TNBC, whatever the age, even if the patient is 20 years old, this is not a curable disease. So you have to understand a TNBC with 6 liver metastasis, even if it is a CR after chemotherapy, it's a palliative case.
I have done some sort of these things in the past and burnt my fingers. Next
Absolutely,
slide.
sir. That is what I was referring to.
Oh,
Sir, could you enlighten us? These 6 lesions, are they lobe specific or they're like bilateral? And based on what you decide the surgery?
Left lobe. Abhishek is a fantastic surgeon. Manthan is a fantastic surgeon. I'm sure they can do very good.
Sir, I would offer only loco-regional treatment, not for the liver, sir.
Okay.
Only for the breast, not for the liver, because the liver lesions have already disappeared. Right. And if there is a residual small
in the breast as well, in the nodes as well. When you offer for local, why don't you offer for the systemic as well? So there were a lot of randomized trials, the TMH Mumbai, Dr. Badwe's Turkish, ABSCG 28 positive study, the ECOG Ecrin E28. We'll see some of them. Next slide. So the TMH trial said that there is no quality of life difference, no overall survival difference. We have to very clearly discuss with the patient that there may be no overall survival benefit. Whether the ABC, there may be good loco-regional control in these patients, and even the ECOG study said that there is no overall survival difference. So once a patient comes with metastatic breast cancer, it's great likelihood that eventually she will succumb to the disease. Next. Can we run through it? So the surgery, why was surgery first of all considered as primary in the metastatic breast cancer? Because there are two models, self-seed model and the immunocompetence mouse model. Next. So this is a meta-analysis for the couple of trials.
Yes, sir. I was about to mention this. Soren et al.
Dr. Badwe, Soran, Fitzal, and Khan, Seema Khan. So most of them have said next. Most of them have said that they give good loco-regional control, but as far as
the Soren trial actually showed a good survival benefit after 5 years. That Soren trial, it was a randomized control trial.
Okay.
And it did show benefit after 5 years, sir. So that was the only trial and the first trial which showed benefit with treatment of the primary.
Any particular subsets, any subset analysis?
Sir, less than 55 years, luminal tumors and bone only metastasis.
Oh,
so this was the 3 category which showed the best result. But overall, they clearly proved that after 5 years, patient had improved survival. Yeah.
Okay. Next. So there is also a lot of data that has been derived, whether solitary metastasis, there is Wekamp et al. Who identify that a solitary metastasis is better than 1. Steenbergen, who said that 3, less than 3 is better than more than 3. And somebody who said that less than 5 is better than more than 5. Next. So, the whole concept of oligometastasis. So we come with something with a more amenable that we see hormone receptor positive, single D3 metastasis in the vertebral body and the right pedicle. She's asymptomatic for this metastatic lesion, which is in the D3 vertebrae. So more or less, I hope that the panel agrees that we will start systemic treatment first and then consider loco-regional treatment. She's strong ERPR positive. She's HER2 negative. So Preetham and Gautam, choice of drugs, chemotherapy, hormone therapy, what? Strong
so this is
only.
Yeah, so this is a 52-year-old post-menopausal T3 N0M1 with a solitary bony metastasis. No, I mean vertebral body and right pedicle. So it's an oligometastatic disease. So again, it's a luminal type. So I certainly want to go ahead with the radical curative intent. In this case, because it is an M1 and 5.5 centimeter and upfront systemic therapy.
What is your choice of drugs? What is your choice?
So the choice is a standard, 4 cycles of AC followed by taxanes, as a systemic therapy upfront.
Not starting with hormone therapy.
No, sir. If I'm going with a radical curative intent, then I would like to start with the systemic therapy, like in any other patients. How we start if it's an M0.
Okay. Like you give for a neoadjuvant setting.
Yes,
Right.
it is as good as
Okay.
an NACT with a curative intent, but this is in an M1 oligometastatic setup.
Gautam.
Sir, agree with Pritam, sir. Agree.
Okay.
I would give aggressive neoadjuvant therapy. Chemo.
Chemo first, followed. Okay. Manthan, Abhishek, Kinjal, any thoughts?
Yes, sir, absolutely. Systemic first, followed by definitely I would want to do surgery later on in this patient, because she might as well end up getting a lumpectomy and ALND, not even a mastectomy. So
One more thing, sir. I would like to keep her on close follow-up. Some of this patient might not be responding that much to aggressive neoadjuvant therapy. So close follow-up is the way to go.
We are positive. Okay. Next
One
slide.
more important aspect that we say, it's a hormonal positive disease. So sometimes they are
Right,
relatively chemo resistant. So this point also we keep it in front of the patients, because sometimes it might not respond to a systemic therapy. It might be a stable disease even at the end of 3 months, like that.
But this kind of patient with a 5 centimeter tumor or a 5.5 centimeter tumor, giving a neoadjuvant chemotherapy, we want to take care of the micrometastasis along with the metastasis. So we are not much worried about the primary side. So even after the neoadjuvant chemotherapy, maybe 8 cycles of 4 AC, 4 X, and then there is a small residual, which is operated, and then we can go for the adjuvant treatment along with the SPRT.
Agree, sir. Agree.
So this is the trial that Abhishek keeps referring to justify doing surgery. Breast cancer. I know. I will ask you
to stay relevant, sir. To stay relevant.
I am reading this trial. So hormone receptor positive, HER2 negative patients younger than 55 years, solitary bone only. It's a very, very small subset of patients in whom we can do surgery. But I'm sure that with more systemic treatments available, there might be a role for doing local regional treatment in metastatic breast cancer. Next. So it's a question of sequencing. Now, I think more or less the panelists have agreed that very few, in colorectal cancer with liver metastasis, I hear in the surgeons discussion whether we'll treat the liver mets first, the colon lesion, the rectum colon lesion first, or both together, or systemic treatment first. So I think that model is evolving. I think currently standard of care would be systemic treatment first, followed good responders will go for loco-regional treatment. Next. Hitesh Katwani, at any point of time you want me to cut me off, and the panelists, we will be more than happy. Next, previous slide.
No, sir, this is the last panel, so you have to decide when
Nobody
to stop.
waiting else apart from this.
Next. So there was this SABR COMET study where oligometastatic cancers, Kinjal, I'm sure you are aware of this. You want to say anything about this? So the metastatic site was treated with a curative intent.
So so the radical treatment, whenever it is given, a radical treatment to the bone is always better than doing a palliative treatment. So when you give, like when we used to give 30 gray 10 fractions, that was a suboptimal dose. But when you go for an SABR, we tend to go around equivalent dose of around 60 gray to 70 gray. So definitely these are the patients who are going to do better. And I and Vijay sir have treated, I think around 20 to 30 patients with a radical intent for oligometastatic, where patient have been given neoadjuvant chemotherapy followed by surgery, followed by adjuvant radiotherapy plus the SPRT. So these patients are comparatively doing well, and specifically the luminal A type of patients or a HER2 positive.
Next. So with extended follow-up, the impact of SABR on overall survival was larger in magnitude than in the initial analysis, durable over time. No new safety signals. SABR had no detrimental effect on the quality of life. Next. Dr. Chamura is a surgeon in the US. He was offering ablative treatment options to his patients with hormone receptor positive, HER2 negative oligometastatic So NRG BR002 is the trial. Women with limited breast cancer metastasis. So there are some people who believe that, patients with breast cancer, limited breast cancer metastasis, they appear to have a different natural history than those with more extensive disease, and that surgery, loco-regional treatment might not have a significant impact in the outcome. So the jury is still out. There are, you have to define institutional protocols and do your own data, whether, like Kinjal said, that we have done some 30 patients. Next. So next. So this is in the liver. Next. And she was positive, asymptomatic, like next. Abhishek. Next. Abhishek pointed out that there is some controversy. Next. Some people might go for next, depending upon the number of lesions, visceral, whether it is visceral, whether we can do local regional treatment, metastatic site. Next. We would always treat Abhishek and Manthan. I hope you will agree to me that we will give local regional treatment depending upon the
size of the tumor.
Depending upon the findings at that particular time. It is amenable to breast conservation surgery with local regional radiation, chest wall. Yeah, next. I think I will just run through the next few slides. I think this slide was given to me by Hitesh, if I'm not mistaken. Next. And 3, next. Please run through the quickly. Yeah. Or next. Next. Yeah. So this is, keep this slide. So to conclude this particular debate, whether brain metastasis would change our approach, that has been a continuing controversy because, they have very poor outcomes. Whether the patient can afford targeted therapy, NRB 002 trial, whether it has changed our practice, whether we should define any new biomarkers by which and follow-up of these patients with metastatic breast cancer, and what to do in patients with metastatic breast cancer who have 5 years after control of local disease. Next, last slide. So although the retrospective data and Turkey study suggests that local regional therapy may provide a survival advantage in women with metastatic breast cancer, this is not confirmed by 2 randomized study. Please remember that even in the Tata study, many patients did not receive, even HER2 new positive patients did not receive trastuzumab, let alone pertuzumab. What effect these drugs will have on the huge impact. The biases of the retrospective studies weakens the reliability of the effect of surgery on stage 4. Surgery, I think the panel agrees with me, young female, oligometastatic, bone only, good response to systemic treatment, hormone positive, maybe even HER2 positive, in whom we can consider trastuzumab, pertuzumab. And for the patient in whom distant disease is controlled, but the primary site is progressing, surgery provides a reasonable approach. Last slide. That is the team at HCG Cancer Center, the Astha Oncology Associates. Thank you very much. Thank you, panelists. Thank you, organizers, for having given us this.
Sir, I would like to make a point, sir.
Yeah.
So there's a one randomized trial, ECOG trial, which is still recruiting patients and still going on. And I think next year, from next year, they'll start the analysis. So it's a much awaited trial. And there's a standard 2-arm study, palliative versus treatment of the primary. So I think this might give us some answers to this debate.
Me too would like to add something, sir. Based on our experience, 2 years back when we were in Narayana Hospital along with Rishabh Kothari and Dr. Hitesh Khatwani, based on the definition of oligometastatic, we used to treat the breast carcinoma with just mediastinal lymph node metastasis, like stage 3 with curative intent, considering that radiation oncologist will radiate the mediastinum. At that time, we were not including the radiotherapist in our tumor board meeting because it was not available. But now our experience has changed, and after discussion with tumor board in the tumor board, mediastinal nodes are not amenable to the curative intent radiation. So this is very important while treating the MBCs, oligometastatic, to incorporate the patient in the tumor board discussion whether all the metastatic sites, including the primary, are amenable to the curative control or curative treatment after the
Correct.
systemic therapy. That is very important because in
Correct.
some
You have
patients,
hit
even
the nail
bone
on the head.
metastases are not amenable to treatment.
Absolutely.
Absolutely
Preetham,
right.
last word.
Manthan, you are
Sir,
absolutely right.
Preetham, last word.
Sir, I would like to have your expert opinion in one of my case, which I got stuck in quite a similar fashion. If you permit me for a minute. You see, sir, I had a similar case 3 months back. She was a 40-year lady who got diagnosed as CA breast, undergone BCS, followed by adjuvant chemo and radiation therapy. Then after 7 years, she had a loco-regional recurrence. And she was BRCA positive with a strong BRCA family, sir. So this time the surgeon said, okay, we'll start with neoadjuvant. For the reason is because on PET-CT, there was a local tumor in the breast, plus there were internal mammary lymph nodes. However, there were no axillary lymph nodes because the axillary lymph node dissection was done in the past. Now, sir, I would like to have your opinion that I would like to start with the neoadjuvant chemotherapy. In this case, I completed DOSI plus no platins in 6 sessions. Patient had an excellent response. Would you like to define these internal mammary lymph node at the very outset in the beginning before we start systemic therapy? Or just based on your PET-CT, you would like to consider this as metastasis unless proved otherwise?
I have reviewed the data extensively on internal mammary lymph nodes. The internal mammary lymph nodes are not enlarged unless they are metastatic. So the likelihood that the internal mammary lymph nodes are, granulomatous or reactive is very rare. So they should be. It's impossible to, sort of biopsy them. We have done internal mammary node dissection, but they have to be considered as metastatic unless proved otherwise. So 7 years, I think, is an excellent disease-free survival. If Kinjal is ready to re-radiate, we might consider BCS.
Yeah.
But my first thought that comes to me reflex is to consider a mastectomy with or without a reconstruction. Consider a BRCA because she has a young lady with recurrence. And include the internal mammary in the field of radiation.
Yeah. So I got a difference of opinion when we referred the patient. In fact, patient went on for the opinions for radiotherapy, and patient was denied radiation and was told that the internal mammary lymph node should have been defined upfront, and hence they did not give radiation, and then patient was in a state of confusion. So I would like to know what is the standard of care, or is there any standard consensus for this? Radiation oncologist can also help us.
Yeah, so I would agree with what Dr. Vijay said. If there are internal mammary nodes seen, usually they are not tuberculosis, not infective. So if there are internal mammary nodes, you have to consider them as a metastatic internal mammary nodes. So this patient would have gone for a re-radiation, and now it should be covered. Should be covered. Yes.
And 7 years ke baad kya hua? Because the lymphatics were not going outside to the axillary lymph node.
They bypassed.
Place or a new primary developed, the lymphatics went to the internal mammary. So,
right.
So is there anything new technical approach that robotic induced these internal mammary node biopsies can be done with the help of robotic?
Definitely. Why not? Minimally invasive. Why robotic?
Because this was the explanation given by the other institute, MDT.
They had suggested a biopsy of the internal mammary node.
What they suggested that the biopsy should have been done before starting systemic treatment, so that you could have been deferred from radiation.
Okay. Document whether the lymph nodes were involved.
And they said nowadays it's a robotic techniques are best. They can easily do the biopsy for IMA.
So without robot also, that's what I'm saying. Without robot also, you can do it by means of thoracoscopy.
So what do we do? I mean, like, should we, I mean, like, consider this or like what? Or we irradiate?
I would
Safety point
consider
of view
it as
also, of course.
metastatic and radiate.
Radiation.
Abhishek,
Definitely. Why? What's the size of the node?
They were like 0.5, 1 centimeters, but they were multiple, like, you know, level 1, 2,
Okay,
I mean, like,
okay.
they were there. 2, 3 nodes were there.
Basis.
Right.
Sir, can I ask one question? So role of intermammary node dissection in such cases or only radiation?
Residual disease after post NACT.
Or even if they're positive on day
Residual
one?
lymph node after post NACT.
Or even if they disappear after NSCT, but they are available on
They
day
still
one?
should be radiated, I guess.
Then include in
They
the
should be radiated.
pre-radiation.
Should be
Like
radiated.
supraclavicular.
If they were positive, whether it is CR after chemotherapy, you should radiate.
So in my case, what I did, patient did not undergo radiation because of the difference of opinion and whatever they got confused. So I started them on adjuvant PARP inhibitors considering high risk, and they were BRCA positive.
Right.
Okay. I think with that we conclude my presentation on local regional treatment in metastatic breast cancer. I hope we did a good job. I thank the panel. I thank the organizers. Over to Hitesh Katwani for his vote of thanks.
Thank you, Dr. D.J. Vijay sir, and all the esteemed panelists for having a wonderful discussion. With this, we come to end of this 2-day session on breast cancer. I think we had discussion regarding everything right from molecular to early to metastatic and oligometastatic breast cancer, and I think everyone of us would have learned something new. I hope to have some future discussions and future conferences in near future also. I would like to thank all the esteemed faculties, my colleagues, and my dear friends who joined and made it possible. And also my heartfelt thanks and special thanks to all the academic partners, Team Healthy Blossom and Team Oncowin. With this, I think we'll close here. Thank you everyone and good night.